Уважаемые коллеги, доброе утро.
Distinguished colleagues, good afternoon. We're still waiting for one speaker to come, so I invite you to wait for another minute, and we will start exactly in a minute.
Не подскажете, у нас связь есть с докладчиком из Копенгагена?
Have we established the connection with the presenter from Copenhagen? Could you clarify, please?
Еще раз доброе утро, уважаемые коллеги.
Once again, good morning, distinguished colleagues. I would like to thank everybody for finding the opportunity and joining us today in our session, not only here in the offline format within the World Trade Center, but also I thank those who's joined online. I see that a lot of colleagues are watching us online and participate in this session in the remote format. And so today, within our reports and discussions, if you have any questions, our speakers will be very glad to answer them in an online format as well as in the offline format. I would like to open this session of today's, which is called the Development of Regional and Global Networks to Detect and Respond for Epidemiological Emergencies. And today, during our session, we will listen to Dr. Jukka Pukkila from the WHO Regional Office for Europe, the team leader of the Division of Health Emergencies and Communicable Diseases. Then we'll listen to Igor Karnaukov, the head of the Epidemiology at Microbe, the research institute. Then we'll listen to Elena Shamal, the advisor of the Department of Cooperation and Social Affairs, Administration of Humanitarian Cooperation, Political and Social Affairs, CIS Executive Committee. And then we will listen to Dmitry Lyoznov. He is the director of the Research Institute of Influenza, Russia. So the pandemic of the novel coronavirus infection has shown us the importance and great significance of networks, the groups of people, as well as the importance of communications. It all helps us to identify in a timely manner and respond some outbreaks of diseases. The networks, or in other words, these groups of people, can be built upon absolutely different characteristics. They could be some professional networks that deal with the transfer of information from one epidemiologist to another one. There are also other networks compiled upon the geographical criteria. For example, the CIS countries Council. There are some other networks as well that gather some medical professionals who work in order to respond to emergencies, in order to help to respond to such emergencies, for example, as the outbreak of infectious diseases. For example, we have a global network on the informing and responding on the infectious diseases, the Concurrent Session network. There are some other networks that are being coordinated by WHO, And here I mean the network of contact peoples on the international health regulations. And I'm sure that the next presenter will tell us about this network and about how it was functioning during the outbreak of the novel coronavirus infection. So I invite you to listen to the presentations that will tell you about different formats and ways how to unite people, professionals. And I also invite you to think about how our activities regarding the response to the novel coronavirus infection in the end of the last year and in the beginning of this present year, how it influenced the ways of the existence of these networks. How have the networks become more useful and demanded or less? What are the challenges? What lessons can we draw from the functioning of these networks? What can we learn from the ways that people communicate with each other, how the information is transferred, and how it all influences the outbreaks of infectious diseases as well as other emergencies? And so now I'd like to give the floor to our first speaker, Dr. Jukka Pukkila, the team leader, Division of Health Emergencies and Communicable Diseases at WHO Regional Office for Europe. Jukka, hope you can hear us. Please, the floor is yours.
Jukka, say it again.
Hello, our colleague cannot hear. Can you hear me? It's Jukka Pukkila here.
Yes, Jukka,
I
we can hear you.
But not any others.
Okay, Dr. Liosnov
Yes.
is on call. I can see him, but I'm not sure if he's on call. So can I start my presentation?
Да, Jukka, вы можете.
Yes, you can start. Please go ahead.
Confusion. I'm sharing my slides. Can you see my? Can you see my slide?
Да, Jukka.
Yes, we can share. We can see your screen. It's all working all right.
So, good morning to everybody. Respected chair, the hosts, and the organizers, ladies and gentlemen, dear colleagues. And my name is Jukka Pukkila. I work in the WHO Regional Office for Europe in Copenhagen, and I'm the program area manager for so-called Health Emergency Information and Risk Assessment Department under the WHO Emergency Program for Europe. And the key task of my team's key tasks is to function as the international health regulations regional contact point for the Europe, maintaining the 24/7 duty officer, so we are always available for communication with all the 55 international IHR national focal points in all the European countries. And I have been in this job since 2010 in charge of these IHR communications, so 11 years out of the 14 years when the IHR 2005 has been in force. I start my presentation in a bit unusual manner by immediately bringing up the key messages, or basically the conclusions, what I would like to highlight during my presentation. And when speaking about new networks and developing further regional and global networks for managing public health emergencies and especially epidemics and outbreaks, I still would like to draw everybody's attention that we already have a very long history and a well-developed basic framework, legally binding framework of the international health regulations that we would need to make fully functional. And I can say that during these 11 years, I have never seen that these formal IHR communications regulated by Article 6 to 11 of the IHR between WHO and the national IHR focal points and between various national IHR focal points would have been working as rapidly and as completely and as well it has been working from the very beginning of the outbreak in the European region in January 2020. There are only very few exceptions where this has not been working. But the COVID pandemic has clearly shown to everybody how it affects all sectors of the society and how everybody needs to be involved in managing this. And this has been always the basic message on the IHR, that it is not a specific task or network for ministries of health, or even more narrowly just for this IHR national focal point, which tends to happen sometimes that everything is left to them. It really is supposed to be a whole of government business, and we will need to get it implemented as in the whole of all sectors on the basis of whole of government, and then we need strong political commitment from the highest levels of the government and from the society as a whole to get the IHR working as it was intended to work. So although some sections of some parts of the IHR have been working extremely well during the pandemic, there's definitely much space for improvement. And of course, the national IHR focal points are not the only network. There are many, nine or more core capacity areas under IHR, and there are specialized networks like for laboratories, for points of entry, and for many others already existing, already outside the NFPs. The functioning of the IHR during the COVID pandemic is now being very carefully examined with an independent IHR review committee. They also examined the functioning of the IHR after the 2009-2010 H1N1 influenza pandemic and after the 2014-2016 Ebola outbreak in West Africa. And now they have been doing extensive work on the functioning of the IHR, and they will present maybe not their final results, but at least their findings so far during the World Health Assembly now in May, next month in May. And I would encourage all the member states to pay attention and proactively participate in these discussions, how we can further improve the implementation and perhaps even the content of the IHR going forward, to make it do what it was designed to do. And then just a short look into the history. So the IHR actually goes back a couple of hundred of years. It actually initiates from those yellow flags from 17th century when the ships were required, if they had serious communicable diseases on board, to stay out from the harbor and put a yellow flag into the mast as a sign of the quarantine before they were allowed then to dock and embark. And that is why the first international health regulations booklet was also yellow, and the yellow card is under IHR is that color. And during the existence of WHO since 1947, the first form of international health regulations were the international sanitary regulations that were adopted in 1951 in the Fourth World Health Assembly. Then they were first further developed, and the first edition of the international health regulation was approved in World Health Assembly in 1969, but this first edition concentrated on certain communicable diseases only. And in 1995, the World Health Assembly requested a revision of this IHR. It was seen that the situation has changed in terms of the volume and speed of international travel, and trade, and also that communicable diseases are only some of the public health emergencies, that the IHR should cover all hazards, including chemical, environmental, radionuclear emergencies, and so on. So there was then 10 years of negotiation between the countries to come up with a new version of the IHR, and that was then adopted in the World Health Assembly in 2005 and entered into force 15th of June 2007. So it is now soon 14 years when the latest version of the IHR has been in force. And it's a legally binding for 196 states parties, practically all countries of the world. 55 of these state parties in the European region, even we have only 53 member states, but since Vatican, the Holy See, and the Principality Liechtenstein are also so-called states parties to IHR, we have 55 in the European region. Then I'm not the only text from the IHR itself that I included in the presentation is the Article 2 that provides the purpose and scope of the international health regulations, the current version. And I'm not going to read it aloud here, but that really, when you go through the text, you can see that this is exactly the purpose of the international health regulation, to be able to rapidly to prevent and to rapidly control and respond to public health emergencies caused by any hazard. So this is really something that we already have and we should be building on. Then I have sometimes tendency to go, I don't think that there are many IHR national focal points, and it's not the purpose to speak about the details of the IHR architecture and key functions, but I want to highlight the central role of the national IHR focal point in the system. And then that means that this national IHR focal point really needs to be an institution, and an institution that is centrally located and has access to all the required information, both from health sector but also from other sectors. And of course they cannot function if the national health system and surveillance and response systems are not functioning, both in the health sector and in other sectors where early warning and surveillance of events is required. And for us, the national IHR focal point for WHO is the key counterpart. So we always go to the national IHR focal point. We don't bypass the IHR NFP in WHO. And there are the formal communications regulated by Article 6 to 11 of the IHR in terms of especially this early detection, assessment, reporting, and mounting and timely and appropriate response to any public health emergency, serious public health emergency. So these are the formal communications that are very precisely defined. Then I have to say about the notification that unfortunately the language is a bit negative, and then many times it feels that the countries think that having to notify something under IHR to WHO is a failure. We see it as a great success and a sign that the surveillance system and early warning systems in the country work, so it should never be seen as a failure. When in doubt, rather notify than not notify. And there to WHO. And then these are really the formal IHR communications in this part of the work. And almost as an extra plus, there is now the global network of 196 national IHR focal points, and every national IHR focal point has contact details, so they are free to contact any other national focal point anywhere in the world to share information. We, as a WHO regional contact point, we never contact the national IHR focal points in other regions. We go then through the respective regional offices and through headquarters. But you, as the national IHR focal points, are absolutely free to contact each other. And this is used more and more. We are not at all copied all the time, so we don't even know how much this network is being utilized, but it is increasingly being utilized, and especially for international contact tracing purposes. And we try to facilitate that this would become even more easy and effective to share confidential information between countries through this. Then, concentrating on the very beginning of the pandemic, I'm just highlighting some what has happened using the IHR during the COVID-19 pandemic. There's a link to the timeline of 1 year of WHO Europe response to the COVID-19 pandemic, the whole so-called incident management system team. So it's not limited to us and or only to the IHR. But there is a day-by-day cases at the timeline that you can scroll and see the key events and developments, what happened. So I encourage you to visit that one. So already in January, when we learned about this outbreak in China, and when the virus was identified in the very beginning of January, WHO shared case definitions of this new disease and guidance on the mandatory notification and reporting of all probable and confirmed COVID cases to WHO. And indeed, on Friday evening, 24th of January, France was in the European region the first country to notify the first COVID cases in the Europe, and then other countries, as you might recall, followed in very rapid succession. And whenever we got the information on the first case, we provided a package of the guidance documents and also forms for case-based reporting and so on. And we initiated communication with the countries. The notification is never once-off event. It is always the beginning of the communication. And we had with many countries a series of video conferences to understand what exactly is going on in these countries, especially with Germany, France, UK, Italy. Anyway, you can see those in the timeline, the various. And then we use the existing information sharing channel, the restricted channel for sharing confidential information with all IHR national focal points. It's called so-called event information site for the IHR national focal points, EIS. And whenever there was a new country, we were posting information on that, unless the country for some reason did not want to do that. But it became immediately clear that this is much too rigid and slow reporting in this extremely rapidly evolving situation. So we developed the interactive COVID-19 dashboard in both in English and Russian that came online public webs on 20th February 2020 and has been updated in terms of new cases and deaths every day, 24 every day, including weekends and all holidays ever since. And this is the first time really that we are counting cases when we have over 140 million cases globally and approaching 50 million cases in Europe, and has never been done. Again, here is the main page of the dashboard that has become now the most visited ever WHO Europe website. It has already over 10 million visits until now, and it's visited all the time. And when we are going, we have been adding different information and features there. Unfortunately, on the Russian website, we have the basic numbers. You can see the total number of cases per country and also the 14-day incidence. You can select the view, but then the more complete set is only unfortunately available on the English dashboard side, and the most popular nowadays is the subnational Explorer that is also interactive and where you can see also updated on a daily basis. You can see we don't have the subnational data for quite all countries, but most of the countries we do have, and it really shows where the pandemic is evolving and how the pandemic is evolving. Thus now I strongly encourage you to visit this subnational explorer. There's a list on the whole Europe of all the regions with the highest 7-day incidents. You can see that the Croatia, Sweden, France, this is from Monday, we are leading there. Then, as already mentioned, there are the many other networks linked, and the most important being the joint WHO Europe ECDC flu and network, where all the European member states belong, and where meets with simultaneous translation every 2 weeks, and the next meeting is actually on Friday, day after tomorrow. So this is the key network, and it has been now expanded from flu to cover also COVID, with a COVID surveillance focal point nominated by most countries. And then there are other networks for the response. There is the Global Outbreak Alert and Response Network and the Emergency Medical Teams Network, where Rospotrebnatsor is a member, active member already. So this is on the response side of the, and since we have a presentation on the respiratory surveillance network, I don't need to speak more about that. I just provided some of the key links to the key networks here, but I would like to in the end to highlight the European Mortality Monitoring Activity, or EuroMOMO network, that is supported both by WHO Euro and ECDC, and is actually managed by the Danish Start and Serum Institute, and they are collecting weekly data on excess mortality by any cause, and they would very much welcome additional members to join these members. Israel and Ukraine just joined very recently, but otherwise there's a gap in Eastern European and Central Asian countries. So if you are interested, please pass the message and consider of joining this network to get a more comprehensive picture of the excess mortality in the European region. And in the very end, sorry, I know that I have gone over time, but I still included these key messages with which I started, but I'm not going to go through. It's only the key message is that let's get international health regulation truly to work as they were intended to work, to become a really significant tool for the prevention and control of future epidemics and pandemics. Thank you very much.
Большое спасибо.
Thank you so much, Yuka, for your very interesting presentation about ISR and the network of national coordinators of ISR. And I really hope that distinguished colleagues have got a good understanding on how this network is working and how it is cooperating with other networks that are shaped, for example, on the basis of professional occupancy of specialists, laboratory professionals within the laboratory activities, or like the networks formed on the basis of certain nosologies, like in flu or influenza cases on global, regional, and sub-regional level. Yuka, I would like to ask you not to turn, not to leave our today's session before it will end, because after all the presentations we will have Q&A session, and your participation will be very valuable. Thank you. And now I would like to let the floor to the next presenter, Igor Karnaukhov, head of the Department of Epidemiology of Microbe Institute at the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being. The floor is yours. Thank you. Greetings, distinguished colleagues. Today, I want to show you bits and pieces of information on the measures that were taken and are taken in the EECA region in terms of shaping of unified emergency response system for epidemiological threats in a sanitary and epidemiological field. Could you please manage my slides? Well, as Oleg Nikolaevich today told us, and I also want to stress it out, that pandemics of COVID-19 was a kind of a trigger for shaping of different formats, facilitating the systems of counteraction and uniting our efforts in counteraction the pandemics. But again, in this case, I want to state clearly that the events on shaping of this united system of reaction in the EECA regions, so Eastern Europe and Central Asia, they are facilitated during the last 7 years. That means that the program was initiated in 2015, and I wanted to stress out the fact that the Russian Federation was consecutively supporting the idea of introduction and realization of international sanitary rules starting from 2015. And together with the support of the government of Russian Federation starting from 2015, we are realizing the program which aim is to render the methodological and material and technical support to the partner countries. Countries partnered with Russia in terms of introduction of international sanitary rules and support of these rules. And these programs are aimed on backing up of the national potential of the countries, methodology, technology, also staff potential. It all is leading to enhancement of national possibilities and capabilities of states in the field of sanitary and epidemiological surveillance. And at the end of the day, realization of these programs is aimed on creation, in the first line, of a united information and epidemiological space for the countries of Eastern Europe and Central Asia. And secondly, it is aimed on the creation of a united system of monitoring and operative emergency response for epidemiological threats in EECA. And I also wanted to state that along with the realization of these programs, a leading role is played by the Russian anti-plague institute Microbe at the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, which is the leading organization from the 2015 within the Coordination Council for the problems of epidemiological threats on the territory of CIS. And again, when we speak about CIS and EECA, and we're jumping from one region to the other, like Central Europe, Eastern Europe and Central Asia and CIS, we understand that Eastern Europe and Central Asia is not a union of states, but this is just a mere space uniting the Eastern Europe countries and Central Asia. But when we speak about CIS, this is already official existing union of independent countries and states, and all the member states of CIS are still within the borders of the EECA. And this is just a commentary from my side, because I will speak partly in my presentation about EECA and the CIS correspondingly. The next slide, please. Here you may see the main directions of our cooperations within the framework of the programs that I was speaking about. For example, this is cooperative field work, expeditions in cooperation in terms of monitoring of outbreaks, natural outbreaks of pest and other infectious diseases. And I need to state that this field work was renewed and reconsidered after a long break due to the realization of the named programs. This is also execution of cooperative research works, scientific works, training of medical staff and specialists, which is already and every time a topic for us, and we are using different forms of such trainings, like training courses, online, offline courses, trainings on the basis of Federal Service of Surveillance on Consumer Rights Protection and Human Well-being seminars, and other types of trainings. We are providing for betterment of information and analytical works and support within our work. We are developing analytical and informational systems, which I will disclose a bit later. And we are also supporting material and technical bases, hardware bases of profile agencies of the countries of EECA. And we've performed and are ever performing the deliveries of laboratory equipment, diagnostic drugs and substances, and other substances and materials, also with car-based mobile laboratories. Next slide, please. And further on, you may see the main results of our cooperation within the realization or along the realization of the programs that I stated already. Starting from 2015 to 2020, we've delivered 18 mobile laboratories to the 6 countries of the CIS. And here in the upper left corner, you may see this microbiological laboratory for express diagnostics on the basis of Gazelle car type. So this is a universal chassis that is hosting all types of diagnostics like polymerase chain reaction, immune reaction, luminescent microscopy, immune chromatography analysis. And together with this, we are providing to the countries of EECA mobile laboratories that are the part of a mobile SPEB complex at the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being. We are dealing with Uzbekistan, Azerbaijan, Armenia, Belarus Republic, and we are planning to work with Kyrgyz Republic, which is already stated on one of the sessions yesterday. Astalbek Kabylovich from Kyrgyz Republic is now saying yes to this and supporting these activities. And we ran already a lineup of courses preparing more than 200 specialists in the matters, in the first line, in the matters related to the programs of the specialized anti-epidemics group of response groups. And as of now, we are dealing with the issue of creation of a registry of specialists, profile institutes and agencies, state bodies within the CIS countries that already are covered by the training program of the emergency response groups trainings, and who have professional competencies, knowledge base to work in case of a necessity within a mobile complex of the emergency response for epidemiological threats. And when we speak about the united information epidemiological space and modeling of better exchange in information, we've provided for these purposes automatized workplaces. I mean here computer devices, digital devices that are corresponding to the certain criteria, and I mean modern computer devices. Right now into 8 countries we've delivered 18 automized servers, and on the United Server of Microbe Institute we have digital programs for monitoring of natural outbreaks and emergency response systems. And on the next slide, you may see that as of today, the Microbe Institute has a huge practical experience especially within the scope of reaction to the or response to the urgent emergency and epidemiological threats, and our specialists are ready to share their experience, their best practices to all parties concerned on within the EECA and in first line with the representatives of the CIS countries. What is our experience? You may see it on the slide. This is a participation in fighting Ebola in Guinea Republic from 2014 to 2016. And by the way, there, at the time of 2014, we've launched a group of specialists from the Microbe Institute and Vector Center at the Russian Federal Service for Surveillance on Consumer Rights, Protection and Human Well-being, and 2 special modules of the Unified Emergency Response complexes that were left in Guinea Republic as the gift from Russia. And as of now, these modules are in good operating state there, and they are working autonomously from the autonomous electrogenerators starting from 2014, and now it is 2021, so you can imagine.
And so why we do all that? Because in the Republic of Guinea there are some problems with the power generation, and we cannot work just on the baseline of the regular power grids. And our equipment or equipment of a high cost can just get out of order. And so this is the fact that speaks on its own. Our equipment working autonomously is quite a reliable one, and one can work on this equipment against some difficult conditions. And of course, it's very important that, taking into account the experience and expertise of work in the Republic of Guinea, within 1 year, back in 2016, we created the mobile unit of the emergency response of the 2nd generation. And alongside a set of parameters, it is well ahead of the unit of the 1st generation. And here we also have some training facility to train some personnel for these mobile units. And back in 2019, before COVID-19, we managed to conduct a large-scale international training. It took place in the city of Saratov. We fully deployed the mobile unit of the emergency response, and 72 specialists and professionals from 8 CIS countries took part in that, 82 professionals from 8 countries. And this training was quite a successful one. We addressed some epidemiological tasks, as well as we conducted some research of the samples, of lab samples. We decoded all that, sequenced, analyzed. And it was actually the first time when we conducted such a large-scale intergovernmental study and training. And also we published a guideline, a book, upon the results of this training. And this is a book about the international emergency measures on the territory of EECA. Next slide, please. Another accent that I would like to put in here is that our institute, Microbe, has been researching and developing mobile laboratories since 2006. We obtained 20 patents for the mobile laboratories of the different profiles. Here in the picture you can see some photos of these laboratories. So we have the Express laboratories, the Express Diagnostics. The first one appeared in 2006, and it was the laboratory of indication and the epidemiological surveillance and reconnaissance. Then we've got the second generation of these laboratories back in 2015. So this is a laboratory of express diagnostics. And we supply them to CIS countries. That's what I mentioned before. And as of today, we've already developed the laboratory of the third generation. This is the laboratory of indication. You can see it at the bottom of the slide, in the middle of it. So the third generation laboratory is quite different from the previous ones. It was quite re-equipped, and one can say that this is a new level in developing the mobile labs. In 2017, we developed and designed the mobile laboratory for the monitoring and diagnostics. It was based in the KAMAZ vehicle, and it is aimed at the research of epidemiological monitoring when it comes to the natural foci of plague and some other infections. Next one, please. And here I can't help but mentioning our cooperation with our regional European office of WHO. Since we are talking about the network within EECA, but we do understand that all this is interconnected, and I believe that Oleg would support my words. And here I'd like to mention that the European Office of WHO, with the participation of the Institute of Robert Koch and Federal Service for the Surveillance on Consumer Rights Protection and Human Well-being, we developed the typology of the mobile labs, and we identified and distinguished 5 types of the laboratories, and you can see all these 5 types on this slide. And in Microbe Institute, as of today, we have all the types, perhaps except the first one, the super small labs. We don't have this one, but all the rest of the types are presented and are located in our institute. And this year, we conduct some active work jointly with the European Office of WHO, and we try to achieve such tasks as the development of minimal standards for the mobile laboratories. We also are working on the information support on logistics. We're also working on the organization of international training and drills. And Anna Yurovna mentioned it yesterday in her speech. We plan to organize these kind of drills in autumn this year in the city of Kazan in Russia. Of course, if everything goes well. And we hope that the current pandemic will not thwart our plans. And on the basis of our Microbe Institute, we are working on the creation of the coordinating center of WHO on the preparedness or on being prepared to the pandemics and some responsive measures against the backdrop of emergencies. Well, it's quite a novel work for us. This is absolutely another level. I believe that this is a very useful and valuable work when it comes to the experience and expertise and skills that we will get. It is very useful also within the unified and common network on the territory of EECA. Once again, I'd like to underline that all these processes are intensively interconnected. Well, one does understand that any cooperation in any field, in any area, across every profile and function should be supported by the regulatory and methodological documents. These documents could turn this cooperation into kind of structured work. And we also work on this. We've been actually working on this for quite a number of years, and we do it within the Functioning Coordination Council of CIS on the sanitary protection of the territories. I need to say that it was created back in 2000, and over this time we've conducted 14 regular meetings, and in 2020 and in 2021 we've already conducted and held 7 irregular meetings in a video conference format. These meetings were devoted to the problem of COVID-19. And within the activities of this coordinating council, we drafted 2 very important documents, in my opinion. First, this is the document on the information exchange between CIS countries on emergency situations. And this is done within the creation of a common information epidemiological space. And the second document is the draft agreement on the cooperation of CIS countries in the field of the response to the emergency situations in the field of public health, of the sanitary and epidemiological field. So the first document, the provision on the cooperation within the CIS countries, it has already been adopted. The second document has been approved, and currently it is undergoing as an internal approval within the national states, and after that it will be submitted to the Council of the Prime Ministers of CIS countries. Next slide, please. And another aspect that I believe to be very important. Today, we conduct some work on the creation of the baseline of fundamental organization of CIS countries. It will monitor, inform, and collectively respond to emergencies of the epidemiological and sanitary nature. Rospotrebnadzor, the Russian Federal Service for Surveillance and Consumer Rights Protection and Human Well-being, submitted to the meeting of the Executive Committee. The Executive Committee adopted this initiative, and I believe that this year we will review this issue within the Economic Council. Yes, I see that Elena Vladimirovna notes that it will definitely take place. We hope that this provision will be adopted. The main target of this organization, you can actually see some targets on this slide, and I'll probably not read all of them. Now let's pass to the conclusions. I've already presented to you the main elements of our work, the pillars. But the main conclusion is that as of today, resulting from the activities that we've been doing for the 7th year already, we've built a unified system of monitoring and timely response to emergency situations of sanitary and epidemiological nature in EECA. We unite more than 15 profile units, and we also have created the Situation Coordinating Center on the base of the body, the unit that is working under the Federal Service for Surveillance and Consumer Rights Protection and Human Well-being of Russia. So this is a permanent process. It has not ended. To make the system work properly, one has to be in constant interaction, cooperation. We have to conduct continuous work to that extent, and we do this. And the colleagues who are present in this room today are well aware of all this, and they support us across all our deliberations here. And so I hope that we will continue to conduct some active work in this respect. And I hope that due to our joint efforts, we'll achieve some good results. Thank you. Thank you very much, Igor Gennadievich, for your extensive and informative report. it was very important for us to know more about the coordinating role of your institute and the Federal Service for Surveillance and Consumer Rights Protection and Human Well-being on the territory of the EECA. Thank you very much for your good words on the cooperation of your institute, the Federal Service on Consumer Rights Protection and the WHO European Office. We'll give the opportunity for questions to our audience after all the presentations are done. And now I'd like to give the floor to our next presenter, who is Elena Shamal from CIS Executive Committee. And her presentation sounds very interesting, which is the COVID-19 pandemic, lost opportunities and new horizons. Elena, the floor is yours, please. Can you please put my presentation on the screen? Dear colleagues, can I use the clicker? Or oh, okay, I see that it works. All right. Good afternoon, dear colleagues. As everybody has already said, this topic, this year, the traditional topic of the conference that has always been about HIV and AIDS, this year it has been extended and widened, and over these 2 days we are talking about the epidemiological well-being, about different issues within this context. And of course this is far from a coincidence. I see something happening with the screen. The world situation of COVID-19 is quite tense, and it persists to be tense. The situation in CIS countries with COVID-19 also persists to be quite intensive. So we see that the average indicators across all the countries are more or less the same, but the Armenia and Moldova stand out a bit of this context. At the very beginning of the pandemic, we were working in CIS within the 3 main documents. First, the Agreement on Cooperation in the Field of Healthcare. It was adopted back in 1992. Then the Agreement on Cooperation in the Field of Sanitary Protection. Back in 2001, it was adopted. And the next one, the Agreement on the cooperation between CIS countries in the field of emergencies and liquidation of emergencies. It was adopted in 2015. So COVID-19 is indeed the challenge to the whole humanity, and one country cannot stand alone in it. And here the international cooperation plays one of the key roles and occupies one of the most important places. Then the Executive Committee of CIS countries within the international cooperation interacts with more than 25 international organizations. The main partners of ours are the UN, the WHO, and UNAIDS. The main body when it comes to the cooperation within the healthcare. This is the Council on the Healthcare, and it consists of the Ministers of Health and the Chief Sanitary Physicians from 10 CIS countries. This year, the chair country is the Republic of Belarus, and the Federal Service for Surveillance and Consumer Rights Protection and Human Well-being is the leader in terms of the sanitary and epidemiological well-being. And with satisfaction, I can mention that starting from the very beginning of the pandemic in CIS, we've been cooperating quite in a timely manner. Last year, the heads of our states met twice. And the topics that were discussed, the topics on the COVID-19 were also discussed within the ministers of foreign affairs, as well as the ministers of health and chief sanitary physicians of CIS countries. A bit later, I'll talk about the role of the Coordination Council that fights against the spread and bringing in of contagious diseases. And we also have created a working group to analyze the COVID situation. And on a weekly basis, we publish information bulletins. Last week, we published the 55th bulletin. And another information platform that has been given to us by Macrop Institute. You can take a look at it, and in an online format, you can read easily and write easily your observations and opinions. So yesterday, those who participated in our sessions, you probably remember that Anna Yurievna Popova mentioned and underlined one of the main documents that was adopted by the Council of the Prime Ministers. This is the statement in connection to the novel coronavirus infection. And the initiative came from Federal Service for Surveillance and Consumer Rights Protection and Human Well-being. It was reviewed in the Coordinating Council, and this statement says that the pandemic is indeed a threat to the whole humanity, and the CIS member states are aimed at intensive cooperation to fight against this novel disease. Infectious disease. And separately, the statement underlines the cooperation within the Council on the cooperation, and also there is an order to develop some new documents on not only fight against the coronavirus, COVID-19, but also to establish some strategic approaches how to prevent infectious diseases.
In 2020, there were two meetings of the Ministers of Healthcare and Chief Sanitary Physicians. And the first meeting was the emergency, and there was only one topic: what do we do, how we will interact with COVID-19. And the members of the board discussed the measures taken in the member states, quarantine, events, and the efficiency of quarantine. And also we managed to urgently develop and discuss and promulgate 5 documents on our cooperation within the sanitary and epidemiological well-being. And the meeting of 28th October 2020 was more profound, and the members of the Council discussed the organizational functioning of the healthcare systems during COVID period, understanding that we are not only putting our efforts in fighting the infection, but we also have huge groups of population that need to get help rendered independently of the epidemiological situation in the countries. We also discussed facilitation of works related to the patients with diabetes mellitus, oncology, and according to the Belarus Republic initiative, the set of information materials for the patients with diabetes was developed with the proper recommendations on what to do and how to use it. We also put an accent on the emotional and psychological well-being of patients and medical staff. And within the framework on the Council, we have a basic organization in psychiatry and narcology that is working along this line of works and introducing its own recommendations. A midterm plan. As you may see, this document is also supporting the decree of the Council of the Heads of States, and the main idea is the prevention of epidemic of infectious diseases in member states in general, and building up on potential in fighting against the infections. There are 5 directions, 23 events along this plan, and as Igor Gennadievich in his report stated, he also put some accents. We are going toward the shaping of the overall legal basis and development of the registry of specialists, members of specialized unified emergency response groups. We are also developing programs for support of these specialists, trainings of these specialists, and support of their operational readiness. I will later describe why do we need this. And in part of the development of scientific potential, we are planning the development of cooperative research in immune biological drugs development and other drugs development, scientific expeditions, offline works, aimed on actualization of information on the nature sources of plague. So the plan will be realized in 2021-2022 for 2 years. As Igor Gennadievich stated, we've started the work on the agreement in cooperation within the scope of sanitary protection. During the 20 years of cooperation within this agreement, there were more than 10 epidemics and pandemics in the world. The international sanitary rules are adopted, and again our work was started before pandemics, and we've planned to introduce changes as a protocol. But now we understand that, taking into account the global situation and the features and changes that we're introducing into the international document, today we are ready to provide for a signature of the heads of state the agreement in a new edition. While working on this agreement, we were taking into account not only the necessity of a clear realization and adherence to the medical sanitary rules, but we were one step ahead because we understand that 1 year or two, in 1 or 2 years, the whole world will interact within the International Classification of Diseases of 11th edition. And in this context, we were also introducing changes. And to the agreement, we've attached a list of the diseases for the member states of CIS. That will be supported by the sanitary epidemiological events, respectively. Distinguished colleagues, I want to recall that the pandemics of COVID is not only one question that we're dealing with within our cooperation in prevention of infectious diseases. On the territory of member states of CIS, we have 45 herds of plague, and by the way, in 2019 the Coordination Council developed methodological recommendations that contain the consecutive works and directions for main control and prevention of this hazardous infection on the territory of CIS. Is it a joke or not a joke? But still, I want to say that while I was preparing to the report today, there was a document that was adopted in 2019 with a slight glaze of irony, because in 2019 we were not under a transport collapse. There was a passenger circulation on aviation. Passenger flows on the CIS included dozens of millions, and in the world there were hundreds of millions passengers. And thanks God, today we are going out of this state of limits. But according to the initiative of Belarus Republic, there were 2 documents developed that regulate medical provisions for aviation companies, peculiarities in rendering of medical services to the passengers and crew members within the framework of operations of civil aviation. And one document that let me smile were the methodological recommendations for organization and handling of sanitary anti-epidemic events in case of the dead body or live person opposing the emergency and having the international significance at flight within civil aviation. So we were prepared, although we did not know to what. And distinguished colleagues, as of now, we have a good grade of readiness of one more international document, and this is the draft of agreement on the CIS for prevention and reaction for emergency situations within the epidemiological threats. The ones who were online and offline yesterday on the presentation on the report of activities of the emergency response groups, today our first presenter also touched upon this topic, and this agreement draft has the goal to regulate the activities of emergency response groups in different emergency situations, to make it easier to make cross-border transportation of these groups, and it goes out of the framework of the ministries of healthcare. Here we are inviting for the development of this document the customs, border agencies, and we are optimizing the approaches to shaping of the emergency response systems. We are analyzing their territorial presence, and on the 10th of June we have planned the next meeting on the discussion of this agreement, and we hope that at the end of this year we will be able to pass it for the supreme organs of the CIS. As Igor Gennadievich told in his presentation about the activities of Coordination Council during pandemics, and in 20 years of this Coordination Council, it showed its unity and professional approach in the challenging issues and questions. There are representatives of all 11 member states within this council, and on the sittings of the council, operative meetings of the council, the members of the board are discussing different topics. And with every meeting, the list of questions is being wider and wider. Because if at the beginning of our cooperation there were questions like how, where, and what to do within the framework of special services, what are the events to be imposed, what is working, what is not working, how to organize the activities in schools, in healthcare system, the topics still are very wide. And today these issues, these questions are also getting a new status of the development of knowledge on immunization, use of specific and non-specific preventive tools. And I want to say that the WHO, practically speaking, is cooperating with us on every meeting. We have presenters from WHO, and Oleg Nikolaevich, I want to thank you for this, especially because you are also our colleague and participant of all of these events. And as Igor Gennadievich already told during the first presentation, that in this year the platform of Microbe Institute is planned to be established as a basic organization. And this was the idea that was fostered starting from 2003, because from 2003 Microbe Institute is the basis for operative and informational exchange for the situations and for a certain list of infectious diseases. Therefore, we have many works that are finalized. We have preliminary acceptance, and on the 14th of June, the status of basis organization will be provided for the Institute Microbe. And as I already told, the vaccine prevention as of now is one of very important topics. Study of immune status, the pace of immune prevention, we wanted to increase it, but still I hope that the platform for manufacturing of vaccines, Sputnik V, in Kazakhstan, in Belarus Republic, it will correct the situation, and this issue or this question will be enhanced. And distinguished colleagues, the year 2020 was challenging, and in December 2020 there was the first meeting that was held not only in online mode but also in personal mode, in offline mode within the CIS. This was the international conference organized by the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being. We were discussing COVID, and mobile laboratories were handed over to Kazakhstan, Uzbekistan, and Tajikistan. One more international platform, as I stated, is the UN. And this year we also had a meeting with the Secretary General at the UN in discussing of cooperation of international organizations in fighting against COVID-19. The year 2020 is a challenging year, not only due to COVID-19, but we also remember that the states got this obligation for implementation of the Sustainable Development Goals, and of course HIV, tuberculosis, SDG issues are in the field of our view, and there is a state accepted obligation, and on the platform of CIS, our statistic committee is running analysis and monitoring of the goals of sustainable developments. And we've issued 4 information and analytic compendiums that are showing the situation for performance of SDG. And I want to state here that for the CIS, we are using 111 KPI. 97 of them are common for all states, and 14 are specific for certain states and member states. And in the context of HIV, let us see what will be in 2020, because 2019, we have the results that are showing the increase in HIV infectious cases in all member states of CIS, and tuberculosis and hepatitis B incidence is also showing positive dynamics. But it is a bit early to make any statements related to this, as I would say. As Oleg Nikolaevich told, why is the topic of the lecture this one? Because from the very beginning I told you that on the CIS, within the CIS, starting our struggle against COVID, we were using the way of cooperation within 3 international agreements, and as of now, at the end of the year, we have 6 international documents, and we are also planning, so taking into account the experience of the lessons learned from 2020, we want to start the corrective measures and introduction of changes into the agreement on HIV cooperation. And we are also correcting and will correct our work in filling in the project of the agreement on rendering of medical help to the migrants and members of the families of these migrants, working migrants. So, taking into account all the experiences that we've gained, and here the Healthcare Council within the CIS is working within the Coordination Council for Infectious Diseases, and starting from the end 2019, we went to the development of mixed document, the project of plan with of working with antibiotics, and of course the international platform and international cooperation is the line of our efforts when we are doubling our efforts, when the lessons learned are learned and the corrective measures are taken. And it's very important when we can see the results of our work, and when our colleagues from other international organizations are cooperating with us. Distinguished colleagues, at the end of my presentation, I want to wish good health to all of you. I want to wish you success and free roads, free borders. Thank you very much. Елена Vladimirovna, thank you very much for this very interesting report. It was very interesting to listen to the ever-growing role of the Executive Committee of the CIS as a platform for cooperation, dialogue between different countries, and now this is also UN and WHO. And for the last presentation within our session, I want to let the floor to the Dr. Dmitry Anatolyevich Lioznov, Director of the Research Institute of Influenza, Smorodinov Institute, Russia. Dmitry Anatolyevich will join us in online. Dmitry Anatolyevich, I hope you can hear us. Let us check the connection. Distinguished colleagues, do we have an established connection with St. Petersburg? We are now checking the connection. Dmitry, if you can hear us, you may start, because we see your presentation on the screen. Dmitry Anatolyevich, could you please turn on your camera? I hope you can hear me. I will go on. Yes, so in the year 2017, the WHO and... Yes, I've started. Thank you very much for your patience. So, starting from 2019, the WHO defined the main risks for public health, and you see the list of these main risks. You see that the half of these risks is bound. Unfortunately, we cannot hear the sound. So, and now I want to speak about influenza. This is a socially important disease, and we face the global strategy on flu for 2019-2030. Unfortunately, there is a sound glitch, and still we cannot hear the main presentation.
He is on the general channel that we can hear very vaguely. But somebody should get him to switch to the Russian channel.
Дмитрий Анатольевич, переключитесь на русский канал.
Dmitry Anatolyevich, please choose the Russian channel, because we cannot hear you very well right now. So, the global strategy for flu for 2019-2030 has concrete defined goals. So, to decrease the events of season flu, to minimize the risk bound to zoonotic types of influenza, and to deal with the follow-up of patients, and to provide for a follow-up of flu pandemics. This is our view of the strategy for 2030.
Fortunately, we still can't get the sound from the speaker, so we'll wait until the technical issues are addressed.
Дмитрий Анатольевич, если вы нас слышите, переключитесь на русский канал, пожалуйста.
Dmitry, if you can hear us, please switch to the Russian channel.
Hear me.
Yes, we can hear you.
Could you please send a message to Dr. Lyoznov that we cannot hear him?
Everybody can see your slides but not hear you. You should switch to Russian channel.
К сожалению,
Unfortunately, we had some technical problems. with St. Petersburg. I'm sure that Dr. Lyoznov will share his presentation and it will be available for the participants of this conference. I'd like to conclude and I also would like to organize. Can you hear me now? Yes.
Need some correct link.
No, you need to switch to Russian channel. There's a button interpretation on the bottom of your screen. Can you see that?
I see.
The record
Вот
interpretation.
так лучше? Все.
And
Дмитрий Анатольевич, мы
you-
вас очень хорошо слышим.
Сейчас меня слышно?
How about now? Can you hear me now? The offline studio says yes, we can hear you. I hope, dear participants online, that you can also receive our sound without any problems. So, the pandemic was announced because this is the absolutely new, not absolutely, but this is a principally new virus. It is different from those viruses that were present before, and it can be transmitted from one person to another person, and it can be spread globally. We don't have any immunity, or we have a very low immunity. And for example, we had a situation back in 2009 when the population, especially the population of aged people, had some immunity to this virus. And that's why younger people or middle-aged people suffered most. And we also see some clinical characteristics. So the pandemic doesn't depend on the season. The flu pandemic, also if we look back at 2009, we do remember that it didn't start according to the regular season, as well as it ousted all other viruses that usually used to be present in the season. And so now the influenza or flu for us is quite a seasonal one. It has become a seasonal one. One needs to say that our meeting, so to say, with the pandemic potential can happen at any time. If we take a look at the history of the last 20 years, then we will see that each year we identify some pathogens that do have the pandemic potential. Sometimes it is limited to animals, sometimes some single cases of human infections are registered as well. But here you can see 2009, and there was a virus, PH1N1, and it has become the pandemic virus. Today, in the world, we have the GISRS. This is the program by WHO. This is one of the oldest ones and most successful ones. 121 countries participate in that. In some countries, there are even 2 national centers. For example, Russia also have got 2 national centers in St. Petersburg and in Moscow. We have cooperating centers, reference centers as well. And within this global system of monitoring, or GSRS, we have 2 subsystems, the traditional one and some so-called signal surveillance. So all these systems, especially if we talk about the traditional ones, so we've had there for over last 50 years. So the methodological recommendations were published back in 1967. And over the last years, we drafted 3 systems, and they are working in parallel. That's why we can say that this is the multiplex system: traditional, signal, and hospital surveillance. 3 components. We have different timelines, different regions in which we work. So traditional surveillance epidemiological surveillance. 51 regions are involved in that. Then the signal clinical epidemiological surveillance. It was submitted or proposed to do in 2010, and this system started and was launched back in 2010, and it had and still has 10 bases. And the hospital surveillance, it's been in operation for 7 years, and each year we enhance the number of the hospitals that take part in that. Main goal here is to limit the negative effect of flu, as well as to communicate the information to the authorities to limit the number of morbidity and death rate. And we saw it on the example of the pandemic of COVID-19 last year. The system is being continuously developed. And what I wanted to add, that this is a continuous system. What does it give us? This is the early identification of pandemic viruses, then the identification of the beginning and the end of the seasonal epidemic or pandemic, then the identification of etiology and the severity. So this is not about the clinical characteristics, but this is about the expression of this process. Last but not least, we also aimed at identification of the relevant strains. So antigen characteristics are identified across the whole world, and then the WHO issues recommendations to the producers on the strains that should be included into the vaccines. So this committee gathers in February and says which strain should be included into the vaccines. And so here you can see the routing of our information flow. It all starts with the clinics, and then it is all sent to the Federal Service for Surveillance and Consumer Rights Protection and Human Well-being. Then the information is passed to the Research Institute of Flu. This is for the lab testing and research for sequencing. And after that, on a weekly basis, the Federal Center of Flu Control submits this information to our Ministry of Healthcare, to the Federal Service for Surveillance and Consumer Rights Protection and Human Well-being. It passes all the information on flu. And also our National Research Institute passes this information to the WHO and its regional offices. In our case, it's European office. So this system, and it was mentioned today within the International Health regulations, this information is passed to the governing health bodies. As I've said, the system is being developed continuously, and today we not only talk about the epidemiological data, but also we do the molecular diagnostics and phylogenetic analysis. Here, Russia does not lag behind the colleagues, and in 2015 and 2016, that full genome sequencing was introduced. We were the second country in Europe that did that, and over the last season, we were at the second place on the number of sequenced flu viruses among all the countries of the European region of WHO. And so this experience allowed us to respond to the challenge of COVID-19. We created a consortium on sequencing, and we got more than 82,000 of samples that were studied. And as you know, the Russian Institute of Epidemiology will accumulate all the data that we get on the sequencing of the coronavirus from the whole country. Then the signal surveillance. Here we get additional information from clinics and laboratories. So this is an individual approach. And it is different from the traditional one because the traditional one just registers the statistics. And signal surveillance currently is in operation in 19 hospitals and in 14 clinics in different regions and in different federal districts. This allows us to have more or less a full picture. The system of signal surveillance is quite a standardized one, and it allows us to gather information that can be compared not only to different regions in this country, in Russia, but it can also be a large element in the chain of the world data. We have patients with a severe respiratory infection. They are hospitalized, and we get this information from hospitals. And we also have patients with respiratory infection, and those infections are treated in clinics. And so we have criteria: what is the severe respiratory syndrome, what is just a standard respiratory virus, etc. And then we create an individual card in the clinic or hospital where the patient is held or treated. We take into account the clinical picture, the vaccinal status, and also the administration of antiviral medication. And so in online regime, it is all filled in into the database, and this allows us to use all this information. And this online format allows us to identify the etiology. And so it helps us not to overlook some case that could be quite dangerous and that has the epidemic potential. So here we can identify the risk factors because we get the data from the clinics, we get epidemiological and other types of data, demographic ones, for example, and we also try to assess the effect of vaccination and antiviral therapy for these patients. All the data that we collect is integrated in the system of traditional surveillance, and we integrate it and fill it in the international database. That's how we can compare our situation with the situation in other countries, because the system is quite a unified one. It is a single one, and it was suggested by WHO. For example, during the last season when we had flu, we surveyed the severe respiratory infection, and we decoded the diagnosis for 36% of patients. So 17% of all this was different types of flu, B flu. Then we also have H1N1, and about 19% were suffering from some virus of another etiology. And here we can see that rhinovirus and RS virus are dominating here. And also the seasonal coronaviruses that we always have registered, they account for just about 1% among those patients that should be accepted into the hospital. Also, we can see the demographic data. So what infections are met in which groups of ages. For example, for children from 0 months to 12 months, this is mostly A. And for other groups, we see that other groups suffer more from flu, especially when they're hospitalized. And when it comes to the group 65 years plus, we see that RS virus is also quite common among them, and they can suffer from some lung damage quite a lot. And so when it comes to the traditional and signal surveillance, well, we see the traditional system at the upper part of the slide and the signal one at the bottom of the slide. So the characteristics are all the same, but when it comes to the signal surveillance, this is more personalized, and it allows us to get the data from the clinic. So this is not only about epidemiological surveillance, but also about some clinical data. And another type of surveillance here is the hospital one. It is quite a new and pilot project. We get the detailed characteristics of our patients, since we have some large and extended survey from our patients. Unfortunately, we have just 1 minute to finalize. Okay, so today we see that some hospitals are participating in this pilot, from such cities as from St. Petersburg, Moscow, and last year we had about 4,000 people participating, or patients participating in this project. So to conclude, the global system, or GISRS, is working. It allows us to identify the pathogen quite fast, to help to develop the methods how to diagnose it. There is an interaction between all the organizations within the network, including the international ones, and it allows us to exchange the data on the laboratory diagnostics, on epidemiology, etc. Today, the system has been included into the diagnostics of COVID-19. And I want to state that within this global system and with the support from WHO, we get the agents for diagnostics from WHO, and it on the one hand allows us to work for the benefit of our country, and on the other hand we can also provide the global community with the data that we get. And in the WHO strategy it is mentioned that jointly with the introduction of international health regulations, the flu is still a priority, key priority, and we need to develop our system of surveillance as well as develop everything that is connected with the prevention of flu. And this is actually quite close to other pathogens of infections and, for example, COVID-19. Thank you for your attention. Thank you, Dmitry, for your very extensive and interesting report. Unfortunately, we don't have any time left for questions, so I'd like to very briefly sum up the conclusions of the session that we've held, and let's include it into our resolution of the conference. So first, I'd like to state that the morning discussion has shown that no country, no single organization can face and address the global pandemic on its own. And in this respect, the networks, sub-regional, regional, and global networks play a key role in when it comes to the response to the emergency. Enforcement and the development of regional, sub-regional, and global systems is a priority task, and this enforcement can be done as follows: through the training of professionals, then the creation of databases, registries, the training of specialist professionals. Secondly, we should also coordinate and communicate within the network and within different networks. This is the key success factor, especially against the current pandemic backdrop. And definitely we need to cooperate. Thank you, dear colleagues. This discussion seemed to me very interesting. Thank you very much. Have a good day and have a fruitful day at the conference as well. Thank you.
Проходите, пожалуйста. Здравствуйте. Что? Ну, ради бога, пожалуйста. Уважаемые коллеги, продолжаем работу.
Distinguished colleagues, we are working further because of the timing. Our session is devoted to epidemiology of new COVID-19 in the EECA countries, and I think I will speak as the first one. We are inviting the colleagues. We will start to speak about the Russian case of coronavirus infection. So let me start from the initial positions. 2019 gave us just a new task, and I mean 2020. COVID-19 is a new task for us, and please put my presentation on. Now I will speak about the Russian Federation, and further on I will speak about Belarus Republic. And we try to analyze this topic also now. And the knowledge has no borders, and in-depth study is just opening new lines of study for us. And I will just try to show you a certain epidemiological features and the approaches that are nowadays used in the Russian Federation related to coronavirus infection. Now I will handle my presentation. And so let us commence. Coronaviridae are really known to the humankind from the very beginning. And we know that alpha coronaviridae are resulting in 10 or 20% of diarrheas in the childhood, mainly. And we understand that everybody is now looking for beta coronaviridae, and we know that this is the third occurrence of coronaviridae in the 21st century, and nobody was waiting for such disastrous event related to this particular infection. As of now, I will now speak about the numbers, but you see they are really significant. In the world, we are now over 140 millions of infected persons. Lethality is more than 3 millions, and day-by-day accumulative effect of the virus is providing for median amount of new cases at the level of 600,000 cases, and 15,000 are dying. So we day by day are changing the information. The maximum growth is in Sweden, in France, in Brazil, in Czech Republic, in Italy, in the USA, in Russia, in Great Britain, and in Italy also. And I already specified that this is the case for Russian Federation also, and this is a acute case. The scale of the disaster is identical on the planet Earth. In all countries we see pretty much the same epidemiological trend, which is represented here on this slide. And this particular slide that you are seeing right now is comparing the so-called spring of 2020 and the autumn rise that we are now living in until now. And you see that this disaster is multiple times higher than we've seen it before. And the dynamic of the epidemiological process is related to this curve on this slide. There are different scenarios, but in a matter of fact, when we speak about the second wave or third wave, in terms of Russian Federation, we are not speaking about it, because the classical definition of a wave is zero peak and zero. Russia did not cross the zero line in any situation. Therefore, we are speaking about ever-going, ongoing epidemiological process, spring rise, autumn rise, within the first and the second year. We see all the age categories, and the mortality is growing, and coronavirus infection is also included into this epidemiological process, and there is only one exclusion in children. And when we speak about Russian Federation, as of now, we've surpassed the barrier of 4,700,000 registered cases, more than 106,000 lethal cases, and as of now, when we assess the situation for Russia, we are going that we're going through stabilization of peak processes with this tendency of a decrease. According to the overall registered new cases, we are on the 5th place. Overall morbidity per 100,000, we're on 69th place. Absolute lethal cases, 7th place. Lethality, 60th place, and mortality for 100,000 people in population, we are on the 60th place. When we analyze all the age groups, we can see that all the age groups in Russia are subject to COVID-19. For children, we are estimating 11% of all new cases in 2020. The most vulnerable category were the children until 1 year and adolescents, who resulted in the maximum registration in children. And in adults, we see the maximum vulnerable category from 20 to 65 years old. And again, please put your attention to this, that within the group from 20 to 40 years, we have a prevailing share of males, and in the group of patients older than 45 years, there are more female. So the severity of cases is also represented by this trend. You may see it on the slide. We see that with the aging, we have more severe cases. The red part is the acute cases on the diagram, and it is vividly shown starting from the age of 20. Again, I want to remind that the lethal cases are in all age group, but 65 plus age is the special category. We understand that when we speak about epidemiological process, we need to speak about laboratory diagnostics. No microbe, no diagnosis. I want to remind you that laboratory diagnostics in Russia is affected within the sanitary norms and regulations on the previous slide. And as of now, we've made more than 125 million tests. Russia is on the plateau, 300,000 tests daily, and as of now, more than 1,000 laboratories in Russia, state and private laboratories, commercial laboratories, are testing for RNA COVID. On the 16th of April, Russia is among the 5 main countries in absolute numbers of the tests in the world. Why do we need testing and screening activities for SARS-CoV-2? At first, asymptomatic forms of infection. And you know, I'm 40 years in infectious diseases, and at COVID-19 we could describe by the means of the test the form of virus infection process that is playing a significant role in the infection. So early isolation of the sources of infection, we need to decrease the intensivity of circulation of virus, decrease the epidemiological risks in certain categories, monitoring of changes and evolution of the virus, and monitoring of the epidemiologically significant mutations. And as of now, there is a new situation for Russia. We have registered 304 test systems for diagnostics of COVID-19. The Central Institute of Epidemiology that I represent is one of the developers of the key test systems. Let us start from the fact that in March we registered universal test system that provides for COVID-19, MERS, and SARS-CoV-1. And this is the only one test system out of 300 test systems that provides for one-moment etiology reactions. We are the only one developers of quantitative or definition of virus. There are no other products in the world. Why do we need to speak about quantity of the virus here? It's very important for no symptom or asymptomatic low symptom form also that are sources for the infection. We need to test persons that are crossing the borders of Russian Federation at different stages of infectious process or at the end of incubation period. The quantitative system is very important for forecasting, for screening, or in non-infectious hospitals. This is also an additional test at the primary testing, and it can be used to assess the environment. By the way, in 2020, the Central Institute of Epidemiology issued 75 million kits for definition, and the share on the market of test system is 83% for our institute. Yes, we've had some problems with reagents, with the plastic parts of the test kits because of the lockdown, but the decree of the government of Russian Federation is fully executed, and on the 1st of April we've reported the sufficient quantity of test systems that were designed, and like Revert and Reverta-L and RiboPrep reference tests are also issued and produced by our institute. By the way, what was the way of work of the Central Institute of Epidemiology? In 2020, we've made 2 million tests by PCR, more than 250,000 research by IFA, more than 400 full genomic RNA sequencing of the coronavirus, and we could provide for a significant support of the vigilance and control over COVID in Russia and abroad. And there was also one important thing. We needed to develop not only a test system, but to integrate the test system into the information sources. As of now, we see that we've created the system that is patented and that provides for obtaining of the results of analysis, and during 24 hours to place the data on all platforms in Gosuslugi State Services platform or EMEA system. And here, as of now, there are 16 regions working within this process, and after we get the positive or negative information on the test, it is integrated into informational platforms that are represented here on this particular slide. And I want to remind you that this integration to create this informational database is made within the decree of the government of Russian Federation. What are the most vulnerable categories with the most often positive tests of COVID? Of course, these are pneumonia cases, acute respiratory diseases. And by the way, it was very important fact for us. We were seeing just the different contacts with COVID-19 here. As of now, the main goal of diagnostics is to decrease the time for plastic analysis, flexible analysis. And here, under this situation, our institute created a test system that is of now under licensing. This is LMP kit that provides for a significant shortage of analysis until 1 hour, so we can shorten the time. And also very important epidemiological research is related to the mutations. As of now, we see that N501Y mutation is the main part of the British mutation, South African, Brazil mutation, and other mutations that are significant. And in this situation, we may say that the British stem, and this is the so-called British because for the first time it was eluded at the end of August 2020, it is now seen in 101 countries around the world, and this stem is having increased contagiosity and the mortality by 64%. South African stem, as of now, it is evident in 64 countries, and Brazil and Japanese in 38 countries. Monitoring of the changes of the properties of the coronavirus is one of the most important scopes of our work. And thanks to the Russian Federal Service for Surveillance on Consumer Rights, Protection and Human Well-being, our institute is running full genomic sequencing and bioinformation analysis that provides for forecast of epidemiological situation and analyze epidemiologic landscape. I don't want to speak about why do we need to understand the study the mutation, because we are we are protected from the virus by antibodies, and virus wants to live on and wants to cross the barriers. And the first barrier, the zoonotic barrier, is already closed, and this is the pathogenic process. This process will go on, and we want to put it on hold, of course. The very often mutations are seen in persons with chronic infections, with compromised immunity. From time to time, there is a classic zoonotic transfer from the mammals in persons with a therapeutic treatment, like a treatment with monoclonal antibodies or serum treatment. And by the way, here I need to state that it's a very important moment here that after the introduction of virus in new population, we have single variants, but then the variants may become contagious and dominate. And as of now, all the research is working with two locus, N501 and E484. In the whole world, we are actively tracing this mutation, and we understand here that sequencing helps us to really monitor and assess the situation. And 15 Institute of the Federal Service for Surveillance on Consumer Rights and Human Well-being is running full genomic or fragment sequencing. All these institutes are doing this work, and again I want to say that we are assessing the landscape of distribution of coronavirus. And centrally, Institute of Epidemiology, according to the ruling of the government of Russian Federation, is the main center that accumulates all information. As of now, we have web platform to load the analysis of data, providing for the results of sequencing. And I want to remind you that before we were placing the results in the World Gene Bank. This was a good world practice. And as of now, we have a Russian platform that provides for tracing of serum changes in circulation of coronavirus. And one of the information on the 15th April is registered in Russian Federation. So in Russia, we've registered British cases 192, South African clades 21, 0 of Brazil type coronavirus. But there is also a very interesting position. In 66 patients, we've seen the mutations, important mutations, because we can be reminded that we've got the Western European and Siberian mutation that was seen in St. Petersburg, and their epidemiological role is now under assessment. So the countries of import of coronavirus, there is a firm control, and from yesterday I want to remind you that we have double PCR tests in interval of 5 days, multiple or bound, combined. This is combined to the situation that is on this slide, and there are the countries from which we've got the imported mutant viruses. And here's the distribution on the territory of Russian Federation. It is also on the website of Rospotrebnadzor, Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, of the British, of the Southern African stamps. And here you see the distribution of the stamps like a mosaic, like a puzzle here. But there are some rules of distribution of mutant coronavirus that we are naming the so-called British ones. A very important moment here is a phylogenetic analysis of building of a gene tree and the tracing of the parts of the tree who are maximum distributed. As of now, on the basis of our institute, we've created the National Registry for Gene Sequencing. And here it is the name of it. It is created from the 1st January 2021, and all institutes at the Rospotrebnadzor, Federal Service for Surveillance on Consumer Rights, they are providing for phylogenetic analysis, and in yellow you see the British clade of the virus. Therefore, it's very important to provide operative analysis in morbidity for COVID-19, and the Central Institute, Research Institute of Epidemiology is the main institute here. It's providing for operative reaction. We are preparing day-by-day reports for Rospotrebnadzor. We are analyzing epidemiological situation in Russia for the longer and closer perimeter in the countries of the world, and we are also making short-term forecast for epidemiological situation in Russia. Speaking about Moscow, we may understand that as of now for Moscow we see the phase of stabilization with this tendency of decreasing of epidemiological process. Very important is the circulation of virus. We are not decreasing the quantity of tests, but positive probes, there are less and less of them, fortunately, but still the international criteria of epidemiological state is the index. If it is more than 1, we need to be aware of this epidemiological situation. And by the way, yesterday the city manager of Moscow stated that we wanted, of course, to have the index, the RT index, less than 1, but the trend is unfortunately positive. Just a couple of words about the key element of prevention, because we understand that epidemiology and prevention are bound to each other by one chain. I will not speak about non-specific prevention that is, of course, clearly outlined, and it it is a rule, because in the spring there was also criteria for Rospotrebnadzor developed for lifting of the lockdown measures, and we understand that barrier method like masks, gloves, social distancing, in the spring when there was no vaccine, they could help us with this problem. But let us speak about vaccination. So in the world there are different vaccines. In Russia there are 3 of them. They are for Spago type, to not provide for adhesion of virus and not to start the vaccine. The infection process, there are 3 vaccines registered: vector vaccine, peptide vaccine, and the classical vaccine. They are registered, like Covivac from Chumakov Center. And the scope of vaccination, as yesterday, is here on the slide. We see we've got inoculation of 16 million doses. And speaking about the scope, and Russian is in the 3rd dozen of the countries. And facing this situation, Russia, as a country and institute, see the following epidemiological task. We need to understand the longevity of post-vaccination immunity and preservance of this immunity. Again, with this, we need to assess also in the decreated groups the times for revaccination if necessary, and we also need to follow up the persons after disease and understand when, after the case of the coronavirus, we need to introduce vaccination. And the key moment here is also the development of special test systems. I want to remind you that for the diagnostics of coronavirus, we are using test system for N protein or nucleotides or domain-binding receptors. Test systems that are assessing the post-vaccination immunity have a more finer immunology features. Therefore, there is a mismatch. And after vaccination, if you want to provide, you get the tests, the amount of antibodies, you get the post-infectious bodies. And this is a bit of mixing. Of course, we are engaged in international activities. Let me not speak about this, but according to the decree of the government, we've passed 25,000 cases for 2.5 million of tests for more than 40 countries of the world, and we are working under the aegis of the Russian Federal Service for Surveillance on Consumer Rights Protection and Human Well-being for prevention and scientific and methodological support and diagnostics, of course. As of now, we're working with a line of international institutes like Robert Koch Institute. With Robert Koch Institute, we have a long-time scientific basis and platform to provide for research not only related to COVID-19, and this institute, Robert Koch RKI, is working under the aegis of WHO and other international events and agencies. And this is our inlay for 2020 in popularization and raising awareness on COVID. This is the publishing rate of information that we've got by analyzing the masses of epidemiological cases, and at the end of 2020, at the beginning of 21, we are working. Thank you very much for your kind attention, and let us hope really that we are at the end. We hope that we are at the end and we will finalize the case with COVID. Thank you. Distinguished colleagues, let us be co-chairs today. While I am preparing my next presentation, I will let the floor to Dashkevich Anna Mikhailovna, head of the Department of Epidemiology at the Republican Center of Hygiene, Epidemiology and Public Health in Belarus Republic, COVID-19 in Belarus Republic, the emerging of epidemic, and measures to minimize the risks of disease distribution.
Good afternoon, dear colleagues. Let me thank you for giving me the opportunity to take part in this conference. In the Republic of Belarus, we organized our work to counteract COVID-19 in the beginning of 2020. Proceeding from the study of the epidemiological situation as well as the WHO recommendations, added by data on the new virus, we created an interagency working group led by the Deputy Prime Minister of the Republic of Belarus. And we developed and implemented the comprehensive plan of measures how to prevent the bringing of the virus to the territory of our country. And it provided for the cooperation between different governmental bodies. We conducted some activities on ensure the sanitary control for those who were crossing the border of our country. And another set of measures was implemented to train, when it comes to theory and practice, our professionals, to make our medical organizations ready for identifying and treating COVID-19 patients. And we also provided our framework of laboratories. We expanded our network of labs that were conducting tests. The first infection case in our country was on the 27th of February, proceeding from the epidemiological data, and then we were proceeding from the molecular data, and we concluded that it was brought from Iran. And in March, we registered the infected cases in 4 districts of the Republic of Belarus. They came from Italy and Portugal. And in the beginning of April, the 2 remaining territories of the Republic of Belarus also were registered with some infected cases. So those cases weren't brought from abroad, but they were brought to these regions from other regions of Belarus. And during the 10th through 13th weeks of 2020, we registered infected cases mostly among those people who came from abroad, from Europe mainly, and those who were in contact with those who came home. After that, we identified that the virus started to spread across the whole country. And we had 2 main waves with the peaks. The first peak was during the 20th week of 2020 and during the second week on 2021. And from the beginning of March, we are registering the 3rd wave, the 3rd peak. So we see the upward trend. Currently, the morbidity has stabilized for us. And currently, we have registered 346,000 of infected cases. Over the whole period of monitoring, we identified some cases of a SARS-CoV-2 spread. And we had the chains of infection transmission with a couple of generations. And here you can see a couple of clusters of the infected. The first case was registered among the patient, or with the patient, who first was in Europe. And then we also see some infected cases coming from work, from their home, from their families. And a couple of cases were also registered after the contacts in the medical organizations. Starting from the very first case and up until now, our professionals in the field of epidemiology and sanitary measures track contacts and organize all the measures necessary in those nidi of infection. And on the one hand, this work allowed us to identify and track the chains of infectious cases, and it also allowed us to avoid the extreme numbers of the infected cases. And the majority of the infected cases were registered in Minsk and Minsk Oblast. And on the one hand, it is connected to the number of people living there. So the population of Minsk accounts for 37% of the whole country. And another aspect here is that this is a megacity and it has a lot of neighboring territories. As to the structure of the infected people, more than 90% of cases were registered among adults. And more than 65% were people of able-bodied age from 18 to 59%, and 29 cases were registered among people 60 years old plus. And so the majority of cases among children are registered among adolescents from 7 to 14 years. And so in the Republic of Belarus, to assess this epidemiological situation from different angles and to make informed management decisions, we monitor severe respiratory infections, pneumonias. Currently, as to the severe respiratory infections, this is not an epidemic for us. But in 2020 and during some weeks of 2021, we've seen some changes in the structure of the infected cases, because in the past, mostly children suffered from that. But in 2020, we saw that there were some changes coming. In the majority of weeks, registered some infected cases among adults. As to pneumonia, more than 90% of pneumonias are coming from the viruses, and more than 95% of pneumonias are connected and caused by SARS-CoV-2. Alongside with this, since 2020, we implemented an assessment of the virus transmission of the COVID-19 among our population. We have a system of surveillance. It has been in operation for quite a long time, and we do the surveillance in 18 regions of our republic. Here you can see the results of our work on the epidemiological surveillance. And over the period that was monitored, we see that there is a combined circulation of SARS-CoV-2 and non-flu viruses. And currently, we do not identify any viruses of flu. And here you see the results on the lab testing, proceeding from clinical and epidemiological parameters. We also test who go abroad. We also test people that are working in state medical organizations as well as in the private ones. The Ministry of Health of our republic identified the measures and identified the laboratories that are allowed to proceed with this testing. Our Ministry of Health, taking into account the order by the Council of the Ministers and also to prevent the bringing in of the infection to our country, it identified the red zone countries that are quite risky ones. And we've developed the criteria, and we monitor the COVID situation in these countries on a weekly basis, as well as monitor the measures that are taken there. And we restructure the list of these red countries, red zone countries. We can add some countries, we can exclude some countries, as well as we can adjust the requirements that are set for those who come from these countries home. As to the legal framework, we also have done a lot when it comes to the prevention of COVID-19. Here you can see just a couple of documents within the regulatory framework. And here I would like to pay some special attention to WHO. Well, there was a set of documents and recommendations prepared on the work of our system of healthcare against the backdrop of COVID. We've drafted methodological materials, videos. They highlight the issues of PPE's use as well as the protective clothes use. And as to the methodological base, we drafted the recommendations on how the different production sites should function, those sites that conduct some economic activities. And so we provided for the functioning of these organizations, even when there were some COVID-infected cases registered. So we, for example, organized the summer activities, and it all allowed us to proceed with the regular schedule of the health centers that are functioning in the summer, and none of these units stopped their activities. And the latest recommendations that we developed for COVID-19 situation, it was for some animals. And we developed recommendations for those organizations who work with animals and some cattle. So, the government of our republic developed and approved the vaccination plan. It all starts with the professional risk groups and other risk groups, and it ends with the vaccination of the whole population. And we want to vaccinate 60% of our population. Currently, we are finalizing the first stage of the vaccination, and currently we involve more than 33% of our medical staff for the purpose of vaccination, and we've vaccinated more than 70 people that are in hospitals and more than 18% of pharmaceutical workers. Currently, we've vaccinated over 2% of our population in total, so we have an extensive work to do in the future. So by this, I'd like to thank you for your attention and to wish you luck and health with the fight against the COVID. Okay, thank you very much. Dear colleagues, I believe that we will pose our questions from where we are seated. We still do social distancing, or you can also write something on a paper and then pass this paper to us. Now, I'd like to give the floor to Tatiana Bilichenko, the head of the Lab of Clinical Epidemiology, Research Institute of Pulmonology. She'll be talking about major clinical and epidemiological features of COVID-19 in Moscow. Good afternoon, dear colleagues. I'm very happy to welcome you. I'd like to wish you to stay healthy, wish you some well-being against this current backdrop. And I would like to present you the data that we drafted on the main clinical and epidemiological characteristics of COVID-19 among the Moscow population. For this, I've used the data only the official data from the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, the Healthcare Department of Moscow. We also used international sources as well as the Russian methodological recommendations that were drafted in January and February, and then reviewed on a regular basis by the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being. And we also use some scientific sources and articles. And we also use some databases on the number of infected cases with COVID-19 in Moscow and Moscow region. So the novel coronavirus announced itself on the 11th of December 2019 in China. We will remember this date forever. And on the 31st December 2019, the WHO knew about 425 cases with a severe pneumonia. And during 30 days, this disease was identified across the whole territory of China. On the 11th of March 2020, during the briefing, the Director General of WHO stated that the disease became the pandemic since it spread across 99 countries. And on the 11th of March 2020, Russia officially registered 20 COVID-19 infected cases of some mild state. 15 cases were registered in Moscow, and 1 case was registered with a child. And all these cases were brought to Russia from abroad. After that, the virus was studied thoroughly. The features of this were identified, and the pathogenic mechanism of this virus was proceeding from the contact with the ACE2 or transmembrane glycoprotein CD147. And by this, the virus could penetrate the cell, then start to spread. And that's how the severe damage to all the organs that included or consisted of this receptor started. And ACE2 are present in the human's body, on the endothelial, epithelial cells, on the erythrocytes, in our intestine system, and in many organs of ours, such as the heart, the kidneys, our brain, etc. Also, it is present in the lymphocytes, in the vessels, endothelium, and macrophages. So all the organs where these receptors are located could be suffering, depending, of course, on the severity of the disease. So the dynamics of COVID-19 disease can be observed in here. You see that as of the 31st of May, Russia registered 405,000 people of the infected cases, and well, the majority of this accounted for Moscow. Then, talking about Russia as a whole, we saw the spread of COVID-19 among the population with a higher frequency as compared to the frequency in Moscow. Because in Moscow, we organized quite a high quality and strict system of epidemiological measures. This system allowed to rein in the spread of the infection. But still, Moscow accounted for the most cases of the infected cases up to August 2020. And from the 31st of May through the 31st of August 2020, we registered some kind of a stabilization in Moscow regarding COVID-19. There was a downward trend in Moscow. And at the same time, we saw the rise in the infected cases in the Russian regions. People were coming from their vacation, and for example, children and aged people were coming back from different regions of Russia to Moscow. And in September, once again, registered the rise in the number of infected cases, and it was quite a sharp rise. It spread across not only socially active groups of population, but it also spread across children and aged people. We saw that the number of the aged population, or the part of the aged population, has risen from 11% to 19%, and the morbidity among children accounted for 11%. So we see that in Moscow, less people died from COVID-19 as compared to the whole Russia. It is mainly connected to the timely and proper treatment. So this is not only about the timely diagnostics, but also about the delivery of the medication, the work of the emergencies, the work of the mobile clinics, and we continuously monitored patients through the remote centers. It was organized in parallel with the work of COVID-19 hospitals across the whole territory of Moscow. The primary hospitalization of COVID-19 infected people was done according to the data from the information system that surveilled the morbidity. We saw that 70% of patients were administered to the infectious units, and the patients mainly were placed to the pulmonology units, then to the therapeutic units, and 0.3% were hospitalized to the intensive care units. In addition to that, the patients were also taken to the gynecologist units, coloproctological units, to the physiatry units, and other different units of different clinics. And in isolation. They were once again tested, the diagnosis was confirmed once again, and they received the treatment or medication, or they were reprofiled or transferred to another unit of infections hospital. Here you can see that among 13,000 of people hospitalized to hospitals from the 1st of April through 25th of June 2020, 25% of all the infected people were hospitalized. And the bad consequences took place for those people who were suffering from different chronic diseases. And in addition to this, if there were some chronic diseases registered and identified, we also saw that there was a link with the age. So the older the people were, the more chronic diseases they had. You can see it represented in the red color on this slide. And the more frequently these patients were observed with the very bad consequences of this disease. And we see that 10,700 people of those hospitalized got over the virus, and more than 1,000 died from this virus. And as to the detailed research of the diseased people, of the lethal cases, during the 3rd day and 65th day after the people were infected with SARS-2, 69 male and 54 female patients were examined. As to the 6th of June 2020, the frequency of such diseases as diabetes, the ischemic heart disease, the obesity, the lungs problem, lymphoma, leukemia, some cancer diseases, we see that the risk has risen. And so definitely, dear colleagues, all these diseases, like in other countries, because our colleagues in other countries conducted the same analysis, these diseases are the factors that result in a very bad situation within the COVID-19. And the dynamics of the death rate of COVID-19 in Moscow as well as in Russia shows us that there was some rise in the death rate as it was assessed against all the official cases of COVID-19 among the population. And we can see that there was an upward trend up to the 31st of August.
At the same time, in Russia, lethality arrived at the level 1.73%, and in Moscow, it even exceeded this number. But fortunately, at the beginning of September, on the 5th September, namely in 2020, the mayor of Moscow announced that Moscow starts the round of vaccination of the high-risk groups in terms of COVID-19. These are medical staff, persons related to servicing of people having coronavirus, and also people who are at the nursing homes for elderly people or for people with disabilities, by the use of a new vaccine that was ready at this time to be used broadly. Further on, step by step, there was an increase in vaccination scope. And as you can see, at the end of November 2020, we arrived at a decrease of not only morbidity of population in Moscow, but also decrease in morbidity along Russia, and decrease of the lethality, so lethal outcomes that was related and conditioned by vaccination, by thorough work of sanitary epidemiological agencies, and in time drafting of clinical recommendation, proper training of doctors, of medical staff, huge events of mass raising awareness in population in all aspects, with pain-free covering of all issues that were faced by the population, which resulted in the betterment of sanitary epidemiological regime, better treatment of our patient, and rendering better healthcare services in clinical departments that were working with this patient. Unfortunately, distinguished colleagues, when we are arriving at better results, we are losing our vigilance. At the end of the March, you see that this curve is rising, not only in Moscow, although the rise is insignificant. Lethality was up to 154, but also in whole Russia, because we see the new times when the people are gathered, there is not so cold on the street, there is an increased social activity, and this is also playing its own role on these indexes. At the end of my presentation, I want to tell the things that you already know, colleagues, that infectious disease COVID-19 is affecting whole population, all ages, but the unfavorable outcomes are faced by the people of the elderly age with chronic diseases. The execution of anti-epidemic measures should be obligatory for all people, whether you had your own flu shot or not, whether you had a case in your history of coronavirus, and so on, because we need to finalize the epidemic process. We need to regularly review and better up the methodology recommendation and introduce the achievements that we have for the last year in coping with this infection. It increases the quality of medical help and control of the disease. And vaccination, by the way, the broader the vaccination is, the broader layers of the community will be facing vaccination. Unfortunately, we have the active vaccine against SARS-CoV-2 virus. It will result in the decrease of lethality and morbidity rate, not only in populations in huge manufacturing cities with a high rate of contacts, social contacts, but also in villages. According to the data of the Department of Healthcare in Moscow that are officially published on the website of the department on the 31st March 2020, it was stated that according to 2021, I mean, according to the results of the tests in Moscow, antibodies to SARS-CoV-2 were evidenced by 44% of Moscow citizens. Therefore, colleagues, I want to remind you that with a person who can be diseased by coronavirus infection, we can meet this person every day in Moscow, because there are more than half of them, and clinical measures for us is the way for us to survive for the future. Distinguished colleagues, now you see all the information agenda. Get your vaccine and choose your health. And I want you to choose health and to wish you good luck. Distinguished colleagues, thank you very much for your kind attention. Tatiana Nikolaevna, thank you. So, Mikhail Andreevich Gatkov will provide us with the report on the issues of organization of a work of a high-profile screening laboratory under COVID-19. I beg your pardon because I am not fully naming the persons, but this is one of the leading specialists, and they are representing different scopes. Distinguished colleagues, greetings. I am representing the service that is working on the basis of diagnostics of coronavirus infection, and I want to thank the chair and the organizers for introduction and for invitation of our service today, because we want to share our experience here and tell about some interesting experiences. Just let us have some fun today for you to feel what was laboratory service making. So I am representing the Sklifosovsky Institute, the ambulance support, and our laboratory was among three biggest laboratories in Russia that have seen the major laboratory loads. And as you told, as the chair told, the laboratory executed more than 2 million researches for SARS-CoV-2, COVID-19. Our laboratory has 1.5 million of tests, but it's also a significant amount of research. So yes, I could manage this. So what did we face? So for a long time I work with laboratories in the system of the healthcare, and I am also the veteran here. And what we have seen, there are no rooms for laboratories. We needed specialized rooms, many of them, and in a rapid way. There was not so much gadgets, even in the whole world. There was a lack in equipment. It's a fantastic thing, really. All of the gadgets were manufactured by pieces, and they were sold out by the manufacturers. All the systems of healthcare around the world were pursuing certain gadgets, and there were real competition on who will be the first one to buy the gadgets. Okay, gadgets hardware is 50%, but what about reagents? And here I want to thank the Institute of Epidemiology in Russia and to all test systems developers, because for me, as I have great experience here, this was the fantastic situation, because in a matter of days there was a new diagnostics. Yes, of course, there was a high percentage of non-specific reactions, but they were working still, and in a matter of no time we managed to make a diagnostics real. And this is the humanitarian experiment of the planet, because we are now facing a revolution in medicine, because this is the way of solidarity and of the overall world reaction on the epidemics. Today we were listening to our colleagues from Belarus Republic, and we need to say that we have pretty similar dynamics and pretty similar actions. For the first time we are coordinated so rapidly, and at the same time the coordination was not done on the level of state agencies, but on the level of scientists per se, of our level. And the third moment, there were no staff. Nobody knew how to work with these new methods. No doctors were trained to this. And physically, we had no such quantity of people. But the main idea is, Alexander Vasilievich was telling about this, we've lost the history of fighting against huge epidemics. There was a negative theory distributed, like the epidemics are not the case of today, that infectious diseases are something out of the range, and the world was not prepared to the epidemics, and epidemics went to us, and I'm afraid that this is not the last epidemics, and there were many no's of such kind, and this is a complex set of problems. It is enlisted here. This is not a full complex, but it was faced by the laboratory services of the whole world, and we did not know how and what to diagnose, who needs to be diagnosed in the first line. There were no to the spectrum. We did not know. So, ideology. Very rapidly, the government of Moscow, in a matter of days, defined that you don't have to run diagnostics in all laboratories. You have to create a huge laboratory to provide for mass screenings. And independently, and this, by the way, was also revolutionary, independently from the means of whether it was private or the state, we used the private laboratories. I was at on the key meeting at Rakova, vice mayor of Moscow, and she told us, "Tell us what do you need. We will buy everything." We told, "We will need gadgets." They told, "We will bring you the gadgets," and they brought the gadgets, although the price was high. So we needed to provide for payments for the staff. Yes, they told that for this group of laboratories they will pay everything, and Moscow paid for everything. And we needed to create laboratories of different tiers. We could not create the same laboratories. Therefore, we created the ideology of multiple level laboratories in Moscow. At the same time, the load for these laboratories should be equal to the level of this laboratory. They could not define, or they could not run this the same amount of tests. On the first step, we did not know who needs to be checked. We defined that there are indications. We don't need to create panics like everybody let's go and get your tests. We need to make this definition. We needed to create the flows of patients to understand what are the flows of contingents of risk groups and load on laboratories. For example, in Moscow, we created a staff, and the staff was led not by the Department of Healthcare, but by us. I know in details a person who every evening sat there and defined what will be the load for every laboratory on each day, on every laboratory, and we knew what are the laboratories that we will work with which agencies. And this was a titanic amount of work. We needed to contact polyclinics, take the materials, invite the representatives, then provide for the gathering of all the probes to us, and we had the new deliveries at 10 o'clock in the evening, and we were working in night shifts because Rakova deputy head was telling us that in 24 hours we have to get the results, not later. So the spectrum of the scope of research, we understand this. On the first level, the RNA test, and very important is also the test for antibodies. It is also very important work also in terms of epidemiology. And so what should be these laboratories? Nobody knew about what the laboratories should be. I will tell you about this a bit later. So PCR tests. I am the head of a huge department at Sklifosovskoy Institute. This is an inter-regional laboratory, a very huge laboratory. We ran PCR tests before COVID-19 from 20 to 50 research. We worked 5 days a week, and we had only 2 specialists who were working with this method. And Rakova told us that in 2 weeks we needed to define 2,500 per 24 hours. We needed to work 24/7, and we've made it. And we needed to create the independent branches and departments on the basis of the existing collectives or create new ones, and we've managed to solve this task. What about the scope of research? As I told you, our laboratory made from 20 to 50 researches. By the way, initially, the PCR is not a screening. It was not a screening. It was not used as a mass research, but the whole world was forced to put it into the rail of mass production. And a huge amount was the testing of 300 probes. I met Chinese colleagues, and one of renowned specialists told me, you know, we are making 300 probes, and at the moment we've told that we are making 5,000 per 24 hours. And he told me, impossible. And then I showed how our laboratory works, and we've achieved the result of 10,000 tests per 24 hours. So from 20 in 24 hours, 20 probes, to 10,000. What is the maximum that is possible? Okay, I know there are laboratories, I will not provide for PR of the colleagues, but these laboratories are providing for 20,000 per 24 hours. Of course, this is another organization of manufacturing of laboratory tests. These are different technologies. But at the same time, the loads cannot be distributed equally for all laboratories, because again, these laboratories, as laboratory of Institute of Epidemiology, our laboratory, there should be not dozens of them, but they should be reserve laboratories. They need to persist and work on. I will tell you about this later. We understand that immune chemiluminescent analysis is something else, but still we have the gadgets and hardware, and we are able to make several thousands of research. Now we are making 5,000 of research, and we may make up till 30,000 of such kind of research. What about the venues? This is also very interesting. When we arrived at the question that we need 2,500 tests per day, we told that we have the amenities, we have the venues, and we need to rework them. Okay, they told us from the government of Moscow, high-class specialists will restore everything, but you will work. Okay, we worked. We were covering the gadgets, and we were covered by polyethylene, and the other guys, they were putting ventilation, cabling, and so on. So there are also videos of this, and this was the work on the basis of 24 hours a day, 7 days a week. We, together with the builders. And, you know, together with you, together with all of us, we were making something heroic, because this was the epoch of heroes. We were working together, and we needed to support the flows. The materials should be distributed within one flow, and we described to the builders and construction workers as how we see the material should go into the laboratory from the moment of entering the laboratory until the deactivation of the material. Of course, there were no projects, as you understand. Nobody was stating this. Everybody was working 24/7. And also reagents, reactive materials. These flows were outlined on the papers A4, for example, how the information will be distributed, where we will take off our coat, and when we will take the materials from patients, because we were also admitting patients. And correspondently to this, we were creating the logistic chains. We were making an outline with this, not 2 or 3 people. We were in consultancies with our colleagues. It can be doctor, it can be assistant or administrator. It did not play a role. The very important was the timing of the steps, because one step you can make it in a very rapid way, but it can result in problems on the next step, and we needed to synchronize work on every steps. And we made this spaghetti analysis, the movement of staff along the laboratory, and of course a very important aspect was the questionnaire of the workers who are working here, and we were asking whether it will fit or not, and when we told that it won't fit, some solution won't fit, it was rebuilt, reconstructed on the next day. Specialized rooms. We need specialized rooms for productive minimum. We created for a comfort amenities, additional light, air conditioning, and so on. On the day 10 or 15, there were workers approaching me, and they told me, it is okay, but what to eat? And we've asked restaurants to support, and the restaurants were delivering food 24/7. And you know, then I went to the department, and they told me we are not able to provide for this. And even with the hot meals 3 times a day, the operators of the laboratory are getting this, because, you know, the people need to work in the comfort. Heroic work can be a day, 2 days, a week, but not a year. And of course, complex use of technological amenities, technological rooms. These are rooms for cold storage, for storage, and so on. Hardware. Of course, when we worked with hardware, we needed to work with the automatized and manual methods, and we understood that they are giving us the equipment, but we don't have any knowledge on how to work with the equipment, and we needed also to understand how to use the manual methods. And along with this, we understood that the test systems will be changed. We will get different test systems, and we needed to be adapted to these changes in particular. Therefore, manual methods were also foreseen in our scope of work, and correspondingly, the load was defined according to the value that was prescribed for the laboratory. What about the staff? As I told you, at the initial stages of pandemic, there were dozens of people. But then we had a training of 250 people, about 250, and 150 are working right now. And we were collecting the staff. We did not know what are those people, and those people did not know what they will do. We knew that they have diploma and certificate. The majority of them were not aware of how PCR works. They needed to be trained, and in 24 hours they had to start the work. And this was a surprise for us, because they've managed to do this. There are many different people in the laboratory. I did not know who they are, but I had to leave them for the night shift. I could not stay there every night. And we create mixed brigades, for example. The one who worked for 4 to 5 days he or she was the elder one, he was just the leader of the shift. This is like on a war, you know, like the newcomers. After 1 week, if you survive, you are the old guy. And by the way, the people had different goals. Somebody was searching for money, somebody was altruist, somebody wanted to work for the fame. And we needed to choose this. This is a very important step, and we need to work on this. And I hope that the leaders of some collectives, some staff groups will listen to me, because the situations will be the same. We need to be prepared. We need to work with psychology of collective, of the staff under this extreme situation. Majority of people who went to us, they understood that they are here for a time. So what can you ask from the person who works this part-time job? And this was the job for a night, and many people did not want to work these night shifts. They wanted to work in the other shifts. And this was a huge share of liability for us, because we were working with diagnosis.
How did we address all that? From the very beginning, when we've got a new person, we wanted to provide for the understanding by this person what is his or her goal and what is his or her functions. The newcomers should understand what the team is doing as a whole and what they should do. Well, of course, we had some changes in our personnel, and we had to lay off only 2 people, and we couldn't allow for more. So all these decisions are quite important. Why? Because proceeding from the data from the world literature, and I also believe in that we will face some more pandemics, unfortunately, in the future. And what infections will we face, and what we'll have to respond to, unfortunately, we do not know anything about it. So, on the one hand, we have to preserve these fundamental labs that will allow us to identify some pathogens and to conduct some screening. And on the other hand, we also have to preserve all the technologies and methods how to fight against the massive pandemics. And everything that has been mentioned today should be taken into account. Okay, thank you. Thank you very much. And our next report will be by Elena Meskina. She'll be talking about clinical and epidemiological analysis of disease in children of the Moscow Oblast. Distinguished Alexander Vasilyevich, distinguished colleagues, good afternoon. I would like to present you the data on the Moscow region, Moscow Oblast, in other words. So, this is the second largest region after Moscow. It is close to Moscow. And in these 2 regions, in Moscow, in the Moscow Oblast, the pandemic in Russia started. We have over almost 2 million people, and the children account for about 20%. In total, we registered more than 230,000 cases, and 18,000 were identified within children, so it is less than 8%. So we do see that children suffer less from COVID. As to the dynamics of the morbidity, it showed some exponential growth also among people or among children. It happened in April, then the morbidity rate stabilized. This trend is quite a characteristic and natural one for Moscow and the Moscow Oblast. So, among 100,000 children in Moscow Oblast, about 15,000 were infected. And here you can see the geographical picture of the virus spread. And you see that those regions that were closer to Moscow suffered more, and those who are further from Moscow suffered less. But this is not the only aspect that we should take into account here. So, if we take a look at the morbidity level, then we can draw a conclusion very clearly that the morbidity rate was higher in those or on those territories with a more dense population. But we also see that there are different factors that can affect the morbidity rate. Here you can see the proportion by sex. Well, on the one hand, it seemed that adolescents suffered more from COVID, but if we take a look at different groups of age or by age, well, the groups were affected quite in the same manner. We see that the children under 1 year old suffered more, but they got over it in quite a mild form. So indeed, children under 1 year old got infected more frequently, but they do not suffer more than others. So in total, starting from April through the March 2021, 40 cases are asymptomatic, and during the start of the pandemic, it accounted for 60%. As to the pneumonia among children, well, not a lot of cases. In the beginning, it accounted for 20%, and very, very rarely we identified some severe forms of pneumonia. So indeed, we had just about 60 cases. So judging by proportion, this is not so much. And when it comes to the sources of the pediatric morbidity, we see different, indeed, sources of foci. 75% of children got infected in the foci. And when we talk about the family foci and the sources and the just public foci, then we see that people or children mostly got infected within their families. It accounted for 75%. So on the left side of this, you can see the morbidity rate by months, and in the right, you can see very clearly that when the morbidity dropped during the summer, we saw at the same time that the proportion of children under 1 year old grew. And we can also see that in the beginning of autumn, adolescents suffered more, so their proportion rose. Well, this is quite understandable because they went to school and some other educational facilities, and no measures were introduced during those times. If we take a look at the A graph, then we can see the monthly cases. And the red line is the share of children in the total number of all people infected. And we see that the number of cases is decreasing and the share of children is rising in parallel with this. I believe that this is mostly connected to the fact that children are a focus of our attention, and we continue to monitor them during all the stages of the pandemic. And what I would like to draw your attention to is that when during the summer the morbidity rate fell, especially in August and September, it is visible. I believe that this situation requires some additional analysis. So we didn't only experience the change in the age structure, but we also experienced some change in the forms, I mean the mild forms and severe forms. I believe that it should be analyzed. And if we take a look at the share of children hospitalized among the total number of children infected, we see that when there is an upward trend among children, then the number of hospitalizations when there is downward trend among the infected cases, in parallel, it is followed by an upward trend or in the hospitalization of children. So what I would also like to mention here is that if we take a look at the age, then I believe that the morbidity among babies, we can see it here. This is the marker of the growth in infected cases. So when we experience some growth of infections among babies, then it will probably result in the rise among the whole population. And so this monitoring, the surveillance and epidemiological monitoring showed that in general children suffered less and got infected less as compared to adults. And if we take a look at these graphs, then we can see that well, those who had some contacts with some people infected, they got some immunity. So, dear colleagues, I would like to support all the calls of our colleagues that we should get vaccinated. So the analysis shows that the pandemic development is a complex one. It proceeds from the number of a set of different factors, and these factors change in parallel with the epidemiological process, and it also changes by seasons. And of course, the approach of patients towards the pandemic can affect it quite a lot. And so, of course, it all influences the indicators that we register. So indeed, children get infected less frequently than adults. Then we see the very even age structure. We didn't register any differences per age when it comes to the morbidity rate and death rate. While children of all the ages get over the infection in the same manner. Also, we didn't register any dependency on the age when it comes to the severity of the disease. We didn't see any spike or any rise in the pandemic among children as of today. And the share of pneumonias has always been the same. If we track it by day, by week, by month, doesn't matter. And so, as I've said, children mostly get infected in their family, and children get infected at school less frequently. Despite the very close contacts, but still apparently the contacts at school are not so close as in their families. Okay, thank you very much. Dear colleagues, we will consume a bit of your time because we have another report to present to you. And I give the floor to Arsen Arakilan, the director of Institute of Molecular Biology of National Academy of Science, Republic of Armenia. And he'll be talking about the molecular genetic analysis of SARS-CoV-2 in clinical samples by methods of nanopore sequencing. Okay, thank you very much. I still will try to be brief here. First, I'd like to thank you for the opportunity to be presenting. And now, I'd like to present you the work that we conducted jointly with the National Center on the Prevention and Control of the Diseases. Our institute works within the system of the Academy of Sciences, and from the very beginning of the pandemic in Armenia, which is March 2020, we started to cooperate with the Ministry of Health of our republic, and in particular with our CDC. So, the data on Armenia. The first case was registered on the 1st of March 2020, and as of the 15th of April 2021, we have 206,000 confirmed cases. Currently, about 16,000 people are treated right now. The number of deaths is almost 4,000. So, when it comes to this pandemic and the fight against this pandemic, I can think that this is a triumph of the sequencing methods. Because from the very beginning of all this, sequencing played quite a role, and they allowed us to identify very fast the virus itself, to sequence it fully when it comes to its genome, and it laid the foundation for PCR tests. It also allowed us to analyze the evolution of the virus as well as the circulating genetic lines. We studied the adaptation, and it all helped us to develop the vaccines. So all the areas that are now quite actively used, or all the methods that are currently used in the fight against the coronavirus, it all proceeded from the sequencing methods. If briefly we will take a look at the technologies, well, we have the sphere of application for each of the technologies, and we have, of course, the sets and protocols in connection to the coronavirus. So we see that there is the Singer sequencing. This is the gold standard, but it is highly precise. It has some lengthy reading, but it has a low throughput. And the Sanger sequencing also allows us to conduct with the S gene screening and the screening of those mutations that are connected to the contagiousness of the virus. So the golden standard during the pandemic was the sequencing of the next generation NGS sequencing. It is very precise. The cost is quite normal, but the readings are quite short ones. And also, we didn't have enough equipment for this. For example, we lacked some equipment for PCR, some agents, etc. And we also lacked this equipment for this type of sequencing. And also, the protocol is not an easy one, and one has to have quite an experience to do all this. And one should spend a lot of time to get adjusted to the protocol and the laboratory. And nanopore sequencing methods are also moving forward. First, it could resemble some just toy or simulator that you can show to school students or university students, but we turn them into a tool also to study the virus, especially during the pandemic. And when it comes to nanopore sequencing, it has an advantage of long readings. So you can have some very large part of the genome with a good coverage. As to the library drafting preparation for nanopore sequencing, this process is quite simpler as compared to the sequencing on an Illumina platform, for example. But where there are advantages, there are also disadvantages. The nanopore sequencing is not as precise as the previous methods that I mentioned. But we can provide for some full coverage or good coverage. And if we combine, for example, nanopore sequencing and sequencing for Illumina, then we can get the coverage of genome of 99.9%. So it is quite a good result. For our study, we used the protocol that had been already validated by a lot of scientific groups across the whole world. Well, I will not stop and pause and tell you about workflow a lot. So we got 36 clinical samples that we got on the 22nd and 29th January of this year and the 18th of March 2021. So it was the randomized study. But we had quite high CT on PCR results. So we prepared our library, proceeding from the method that had been described quite a long time ago. We used Arctic panel. It provides the primaries for NGS as well as nanopore sequencing. So we used MinION equipment. It's quite a small piece of equipment. It just looks like a USB stick. So we done it from 6 to 8 hours, and the average coverage of the genome was the 350 X per nucleotide, and our specialist in the field of bioinformatics developed a pipeline for the preparatory analysis of data. So actually, First, we do the pre-sequencing, then sequencing, and then we analyze the variants that were identified in our clinical samples. And we identified the viral lines and analyzed whether the mutations that we found can influence on the efficiency of the connection of primers between PCR and sequencing. Especially, we were interested in those PCR tests that are currently used in Armenia. As of January 2021, January 21st and January 29th, 90% of all our samples identified the lineage 11163, and according to Pango lineage, this is called the Russian lineage, because this lineage was found in Russia mostly. In all the lineage, we saw some standard mutations. We identified it in May, and in this line, we can see some mutations that are quite characteristics of the UK strain 117. And in March, the situation has changed a lot. Out of 12 samples that were sequenced, 10 identified the mutation of 117. And we could compare it, proceeding from the Pango system, to the UK variant. So we see that the situation with variants in Armenia has changed a lot. And if we compare the number of mutations across these lineages, then we can say that when it comes to 11163 lineage, then the average number of mutations per genome is much lower as compared to the UK variant of the coronavirus. We conducted the phylogenetic analysis of these lineages, proceeding from the GSIDE and other database. Our genomes are characterized all within the one branch. They were quite similar to the Europe. Taking into account the airway traffic, we can probably suggest that the transmission of this virus to Armenia was done through Europe to Russia to Armenia, or just from Russia to Armenia, because this kind of a lineage is commonly identified in Russia. On the other hand, the phylogenetic analysis of the sequencing of 117, the UK strain or variant, we can see that our genomes are clustered in different branches of this tree, phylogenetic tree. So some of them are clustered in Europe, some of them with the same sequence are found in Asia and Africa. And we can see that there are different trajectories of transmission of this lineage in Armenia. The most important question that interests almost everybody who work in a lab is whether the mutations can influence the PCR accuracy as well as sequencing. So we also conducted an analysis to identify whether our mutations are located in the regions on primers. And we see that a lot of mutations are localized on primers that are recommended by Arctic Protocol, and we observed it also during the sequencing. We've got some fragments with quite a low coverage of the genome, and we use PCR sets that are proceeding from the CDC primers from China and the American CDC as well. And so we studied whether the mutations can influence these regions of primers. So we've identified mutations in 12 samples for N gene primer, both forward and reverse ones. All the mutations that we found were localized within the 5 ends of this, and so it shouldn't influence the accuracy of PCR. And the samples that we identified and selected were positive along 2 channels, so for N gene and for the other gene. And our results confirmed our suggestions. And a lot of mutations we identified also for primers that were designed for E gene. And some of these mutations were quite close to the site of this primer, and it can influence the results of the analysis of PCR. And well, most sets that we use in Armenia, they target the N gene or ORF1 gene. So what conclusions can we draw? To sum up, well, in general, this strain, the UK strain, got to Armenia in February-March 2021. I'm talking about B117. So those mutations that we found in the genomes of our clinical samples do not influence the accuracy of PCR tests, but we still need to continue these studies. So we have to extend our selection of samples. And the regular and periodic genome sequencing of the SARS-CoV-2 virus strains is necessary for the monitoring of the epidemiological situation, and the nanoporous sequencing is the reliable and accessible alternative for molecular and epidemiological study if there is no access to NGS platform or the access is quite difficult to obtain. Hereby, I'd like to thank my colleagues from different scientific institutions that helped us to conduct our work, and also hereby I'd like to thank you for your attention. Okay, thank you very much. Dear colleagues, do you have any questions to our presenters? If you don't have any questions, then I'd like to thank everybody, each and every speaker for their presentations. And I would like to invite everybody to come to the National Congress, the 13th Congress on the infectious diseases, named after Mr. Pokrovsky, on the Starting on the 24th of May, it will be conducted in the Radisson Slavianska near the Kievsky railway station. So we still have, of course, some limitations of a 50% filling of the room, but still we hope to meet you over there. Thank you.
Программа не сформирована, но 50% вполне зала дышит.
написали, что репетируем, но они еще не закончили.
Здравствуйте.
Greetings, distinguished colleagues. I want to greet all of you. So let us start. The first two presenters are experiencing some technical issues with connecting, but as soon as they will join us, we will represent them. And the first presenter will be Loktev Valery Borisovich, head of the Department of Molecular Virology of Flaviviruses and Hepatitis viruses, Vector State Research Center of the Rospotrebnadzor, Russia. The floor is yours. Yes, thank you, distinguished colleagues. I hope you can hear me, you can see the presentation well. Let us check it. Yeah, leave it like this. Distinguished colleagues, at first, I want to thank the facilitators of the conference for their support and help, for the possibility that was granted to me in joining this conference and delivering on my topic. I hope that in the virtual space there are many people to listen to, and I want to greet also online attendees, and I hope we will get through this. So, vector-borne infections are playing a huge, significant role in our world. And on the first slide, up there, you see the classical model of Zika virus that is a vector-borne infection. It is transferred through the bite of a mosquito. And this here, in the lower part of the slide, you see the Koltsova Scientific Center. So residential areas are 1/4 of the city, of a research and development city, and this strange thing that you see on the right side, this is the Biotechnopark Koltsova. It is also representing Koltsova here. This is the place where we work, where we also live, and where we try to do our research work. Undoubtedly, I think that biotechnoparks and science concentrated cities represented by Koltsova is one of the best places where we can work and achieve new interesting results. So virus taxonomy is showed in the official virus taxonomy. There is the International Taxonomy Committee which for a long time was fighting against viruses in publishing the names of the viruses once in 4 years. And on the level of 2011, the possibilities to print manuscripts at the taxonomy committee were at its end. And there was just a reason. If you will use one page to describe one virus, and at this time we knew 2,500 of viruses, the book with the description of all viruses would become a huge book, and it would be impossible to publish it on a paper. Therefore, the last 10th edition of Taxonomy Committee is now open in open access and online. This is a huge internet resource when in real time you may see everything. And here down there you can see the taxonomy of viruses. This tree is not readable, is not to read, but you may assess it. There are almost 8,000 new viruses that are represented here at 8 types of realization of their genetic program. That means this is the world of viruses with which, in parallel to which we are living and existing. And when we speak about the other species, we don't see viruses. We see and understand, although how the representatives of this viral kingdom are dealing with us. This is the slide that shows possible biodiversity of the viral kingdom. As now we know 5,500 mammal species, 391,000 plant species and higher, up to 10 million of invertebrates, 5 million species of fungi, and 1.6 million of microbes. And if, according to the basic hypothesis that is assumed to be pessimistic, if one species in the Earth biosphere is associated with at least one virus, so the parasite virus, we may think that we are surrounded by 20 million viruses. The pessimists and optimists are here represented because the optimists say, okay, it's okay then one virus for the absolute parasite for one species. But let us count how many viral conditions of a human being, of home pets, or of plants are existing. And you will understand that 1,000 of pathogenic viruses are known for human population, and we understand that biodiversity of the possible viruses is significantly more than we can even imagine. With the red color, I've highlighted two main kingdoms, mammals and invertebrates that live on the planet Earth. Just two main representatives of the kingdom that are uniting us. These are the blood-sucking invertebrates, like a classic example, a mosquito and ticks. So these are the flying syringes that are providing for viruses to go into our organisms, from invertebrate to vertebrates. For a long period of time, it was assumed that the kingdom of viruses, upper level corner, is enclosed to itself, and it is not correlated to the evolution of all life animals on our planet. But in 2018, there was the change in the view of on evolution on our planet, and this shows us that we were all time living with the viruses. They were also in the primal terrestrial animals, and you see this blue sea, Marburg Ebola virus, for example, and according to its phylogenetic features, some viruses in fish were the parenting viruses for the pathogens that we are now seeing in our life. So why our knowledge in filoviruses and other viruses are limited? If we will look at this tree as the tree of evolution of viruses, the red dot is representing all the possibilities that we have right now. This is the system of cultivation on a cell culture, system for growing of viruses on laboratory, pets and animals, and polymerase chain reaction and additional methods of diagnostics provided for a better picture of identification of the viruses that are living in parallel with us as a parallel kingdom. And only metagenomics provided for a betterment in the situation, and it created theoretical prerequisites for us to be able to finally to see the biodiversity of viruses that are encompassing us, and to see all the viruses that can pose a threat to us. I will tell right now only about the taxonomy of flavivirus viruses and the changes that are seen here. Why do I need to limit myself? Because I will not have enough time to tell you about anything else. So what was interesting in this particular family? In the parallel section, we had a lecture on hepatitis C virus. Hepatitis C is the flavivirus type. 14 types are the classical examples of hepatitis C virus. And all you know that although COVID situation was in 2020, but Nobel Prize was awarded to the team that was working with hepatitis C. After this work related to the hepatitis C was done, and following the previous publications related to hepatitis C, and these are the 1990s, I need to state here that the staff members of Vector were also participating at these works. So two staff members of Vectors were the first authors for the article of transversion of hepatitis C, Alexander Kalakhalov, for example, and this article was nominated for a Nobel Prize, and the last author, Charles Prize, was awarded with Nobel Prize for opening of the hepatitis C virus, together with 2 colleagues. But still, in 1996, this article Science, the operators of Vector at this moment provided for a huge input in understanding and creating the situation with hepatitis C virus as we understand it right now. And as it was stated on the virology session today, Russia will pass the All-Russia program for fighting with hepatitis C in Russia with use of the new biochemical drugs. This initiative was voiced by the President of Russian Federation. As of today, this was stated today by the President of Russian Federation, Vladimir Putin. What else is interesting here? Please put your attention that almost a third of viruses today, 51 viruses, is in the last row, unclassified viruses. I will speak about unclassified viruses a bit later, but all the viruses were opened in the recent times. Their roles in the pathology of human beings and animals, mammals, and other species is not known right now. Flaviviruses, as the genus, includes 53 species, 75 representatives, and I will speak about this more or less. So today's phylogenetic tree of Flavivirus genus, you see it is here now represented on the presentation, and it unites all of these viruses, and almost all of them are mosquito-borne or tick-borne. There are different families of mosquito viruses, up to 100 types, 140 types, and the main 5 of flaviviral infections is provided here in blue. You know them, of course: dengue virus, West Nile virus, Zika virus, Japanese encephalitis virus, and yellow fever virus. But tick-borne encephalitis virus is under a question mark. Why? I will tell a bit later. I think we will not speak in detail about big 5 of the viruses. The last pandemics, as you know, West Nile virus in 1999, Volgograd city, Astrakhan, and New York, Manhattan. And starting from this time, in several years, the West Nile virus was distributed on all continents of Russia. In Russia, there are 28 up to 30 subjects of Russian Federation that are regularly registering the circulation or disease cases of West Nile virus in outbreaks in nature. So, although it is transferred through mosquito. And Zika virus, the last pandemics in Zika virus and flaviviruses was evidenced in the last 6-8 years. The WHO announced it as the global threat when virus Zika from the limited regions of Africa went further through the Indian Ocean, from the Pacific, and was introduced on the territory of Southern America, Central America, Brazil, and there was a huge outbreak of Zika virus, Zika fever, and in 6 months already 90 countries announced that they have cases of Zika virus, that people are infected, and the problem is that the virus lives within organism for a long period of time, and it is very seriously affecting the fetus at pregnancies, leading to microcephaly of a fetus. And by the way, we almost managed to finalize the case with Zika virus, and then we faced COVID. Whether tick-borne encephalitis virus will be a part of this grade 5 or grade 6, but when we speak about the distribution of all these viruses in warm tropical zone of the continent, and they affect hundreds of millions of people living on the planet Earth, the tick-borne encephalitis in the northern Eurasia, we speak about this, and actually we're speaking about dozens of thousands of patients with this virus in Russia and Eurasia. The main hypothesis of the tick-borne flaviviruses is built on the assumption that the phylogenography of tick-borne flaviviruses comes out of the Central Africa about 28,000 years ago. 25,000 years ago, there was establishing of the virus Kadam. It was a key ADV which went to the southern part of the planet, and then the major part of the viral masses went through the Iran and Iraq currently, and went to the mid-Eurasia, and Palosan virus went to the territory of Americas. As of now, the tick-borne infections are distributed also here. And if we would speak about the case that one virus of tick-borne encephalitis is provided is existing through the as it only tick-borne virus, we are speaking not only about the bites of ticks, but in one tick a human being can have from 30 to 60 viruses and up to 20 different pathogens. This is the situation that we are dealing with. And just a couple of words about tick-borne encephalitis virus that is speaking about the distribution of encephalitis virus in Eurasia. This is the data of Chinese researchers who found the historical stems of tick-borne encephalitis virus in Himalaya, so Himalayan virus. They made the phylogenetic tests, and then they arrived at the conclusion that it came to the northern Eurasia through the southern part of western Siberia, and it was distributed in west and in east. Far eastern stems that were discovered as the first ones, they are the youngest ones, the youngest stems of the tick-borne encephalitis virus, and the oldest stems are the Siberian ones. And actually, the old virus is the hemorrhagic fever, Siberian hemorrhagic fever virus that that was existing 4 to 4,500 years ago. So the historically speaking, we have also here the color coding of the new stems of the viruses, and we have the non-controlled distribution of tick-borne encephalitis in Western Europe. Now it is a common case for Spain, for France, for Great Britain, for Spain, for Alps, Germany, Czech Republic, Austria. These are the countries where the tick-borne encephalitis is registered, and the territory and morbidity in Switzerland, for example, is more severe than the tick-borne encephalitis situation on the territory of Novosibirsk region, for example. There are many cases, they are acute cases, and this is indeed a huge problem. The new flavivirus that I wanted to speak about, it was born and it was discovered by the team of Vector in Guinea within the program of within the state virus, Kindia tick virus. This is the name of new multi-component virus. Ticks, Cephalus gigi, that were taken from the home cows, domestic cows, they turn out to be infected by this particular virus. What is the most interesting thing in this virus, and what is making it different from other viruses? Let us look at the genome of these viruses. There are 4 segments. If we are used to flu virus, when one virus part is containing all the segments, with this particular Kindia tick virus or Jingmeng tick virus is the same, that one virus particle is having only one virus segment, and for the virus to be distributed further, one cell should include 4 virus particles that has its own virus segment. So actually, as there is a joke within our community, we are used to the fact that sex needs 2 people at least. But then this kind of Kindia tick virus should be produced by 4 units that should be united within one cell. So it actually takes 4 to make it for the virus. So just a simple characteristic of the fragments of the segment. You see the segments are really small. You see the quantity of nucleotides, about 3,000 nucleotides. Two segments are pretty much similar to the consecutives of flavivirus. Two have no analogs. But still, this multi-component virus was discovered, and if it is in ticks, if it is in domestic cows or in other animals, mammals, this also is working with human being as a mammal. And just another interesting flavivirus that we've managed to find. Okay, tick, it is in ticks, is okay, but what about mosquitoes? Mosquitoes, let us represent this African four segments within Jinkman virus in Africa. And when we speak about the mosquito virus, we need to have already 5 segments for the virus to live on and to result in an infection. We know that in apes, for example, this virus is they are susceptible, but not a human being, because we don't know about this right now. This is a rat phylogenetic tree for Jinkman virus in the former Yugoslavia. We have found the Jinkman similar virus, multi-component virus in patients with Crimea-Congo hemorrhagic fever. Crimea-Congo hemorrhagic fever is conditioned by a mixture of viruses, so co-infection, and it is providing for co-living within one cell in one patient. So we've tested this hypothesis in the south of Russia, Stavropol region. This was the article of 2020. So you see this detection of the RNA for new multi-component virus in patients with Crimean-Congo hemorrhagic fever. You see the Jinkman variants here in Rostov variants. This is a multiple component virus that is represented in blood of patients in Stavropol region. RNA Crimean-Congo hemorrhagic fever in southern Russia, European subtype, and new multi-component virus, virus Manich virus. This is the new name of the virus. And then we have the question whether it is broadly or not broadly represented in Russia, and how the pathology is changed for the human being that will get the infection of both viruses, Crimean-Congo hemorrhagic fever and this new multi-component virus, Manich virus. Just some words about mosquitoes. We got used to think about malaria, about but also in some conditions when it's hot in summer and when there are many rains. But let us speak about Siberia, Russia, for example. This is a strict continental climate. The southern parts of Novosibirsk region, and we have here the types of the mosquitoes that are flying in our regions. We have 17 AIDS types of mosquitoes in Novosibirsk region. With green, you may see actually the types of the mosquitoes that were for the first time registered on the territory of Novosibirsk region. And there is a question. So what do they transmit? And what is the role that they are playing in the pathology of human being?
So metagenome analysis has been conducted, and we collected the mosquito samples in the neighboring areas of Novosibirsk, and we identified 40 viruses in these mosquitoes, and 16 viruses we sequenced the full genome, and for 24 viruses, we saw that the genome was represented with the capsid elements, or also with the DNA and other types. So, of course, those mosquitoes are living around our cells, and we do not pay attention to that. But those are different families of RNA containing viruses. So here you can see different types of the families: Partiviviridae, Totiviviridae, Tombosphaeridae, Ilflariviridae, and other non-classified viruses. So a lot of them are connected with the Coquilitidia richardii, and actually they dominate in up to 50% of the population. Here you can see the graph of how the new viruses are presented in mosquitoes. So the gray upper columns, please pay attention to them. They represent the virus sequences that the contemporary databases cannot identify. So those are unknown viruses, and their share in mosquitoes can account for up to 24-25%. And the most taxonomic spectrum here is represented by picornaviruses. Well, you probably are well aware of the classic picornavirus. For example, the polio. So you probably understand the role of this family in the pathology among humans. And here you can see many other representatives of this family, and they are quite serious pathogens for a human being. Well, in fact, this is quite a randomized situation, and we have to admit that the new viruses and mosquitoes live jointly together with us, and we are not well aware of their role in the pathogenetic structure in the human population. So, and also I'd like to mention a bit about the consequences. Currently, we are getting prepared for the publication of about the novel flavi-like virus in the exodid ticks in patients in Russia. So we collected samples from patients in Vladivostok, from 150 patients that were placed in a hospital with some infection after a tick bite. Well, this is quite a common situation. Everybody is talking about tick encephalitis, but here we see that we've also identified a new virus that was in the blood of those patients tested. Hoosikitic virus, this virus was called, and judging by its structure, it is a flavivirus, and it can cause the diseases in a human body jointly with other flaviviruses. And so when it comes to the tick encephalitis, it was combined in a lot of cases, and the triple infection of Hoosikitic virus, the tick encephalitis borreliose was also identified, and there were some cases when Hoosikitic virus was diagnosed, but the clinical picture of the patient that was hospitalized with this, it will be described later. So it all allowed us to catch the sequence of this virus and to proceed with the phylogenesis and the materials. Here you can see the phylogenetic tree of the flaviviruses. This is a round dendrogram, and at the very upper part of the slide you can see the description of all this. So the Baltic virus, you can also see it here. First, it was identified in the south of China, then in the Caribbean region, in the places where people usually go to vacation. Also, Tribanga virus, it was called, and Hoosikitic virus, you can also see it here. It was identified in the Siberian region. You see here 5 isolators, and the Bratislava also is present here. And so we can conclude that this virus circulates also in Bratislava. It is in the ticks, ticks in there. And this is an official discovery, and it was all published in the databases on the sequencing of the ticks. And today, just 3 days ago, the Institute of Pasteur in France published information that they registered quite a similar virus in Europe. But they couldn't connect it to the pathology of a human being, but we did that. Indeed, there is this virus, and it can be transmitted through a tick bite. And here on the diagram, you can see a person and a tick. So the RNA-dependent polymerase was sequenced, and we identified some sequences in Vladivostok, and the same was identified in the ticks in the Novosibirsk region. So the vertical line here can tell us that this virus was quite similar in the tick and in the human being. And so we could reproduce the structure of the genome, and you can see it at the very bottom of the slide. And you can see the NS3 protein and RNA polymerase. And this is quite characteristic of almost all the flaviviruses. And the rest of the sequences haven't been decoded yet, but we see that this structure of the genes already allows us to identify this virus as a flavivirus that is pathogenic for a human being, and it is transmitted through a tick bite. So the incubation period is from 3 to 5 days, and it is characterized by the damage of the upper lungs of the body. So we can also confuse it and mix it with COVID, or take it for COVID. So flaviviruses are quite new viruses, and we managed to identify the new group of viruses. And for 2 of them, we proved that they can be transmitted to a human person, a human being, and so the Nobel Prize was in 2008 given, and you probably know that the right virus is the HIV virus, and it won the Nobel Prize. The discovery of it won the Nobel Prize. And here we can also see the smallpox virus. And in 2002, the sculpture that wanted to create the virus model, they presented the hypothetical virus that will damage the humanity in the upcoming future. So that installation was presented in 2008. And in the upper part of the slide, we can see the glass model of the coronavirus that results in COVID-19. And you can see that the artist guessed many years ago what virus will humanity face in the future. And so 2020, this is the hepatitis C virus and the Nobel Prize for that. And when the next Nobel Prize will be given in connection to the liquidation of the pandemic caused by COVID-19, I hope that it will be given in the upcoming future. So currently, everybody is studying the coronavirus. The work has been done in quite an extensive way. Just yesterday, I took a look at the articles in the referred scientific journals on the topic of COVID-19 within a little bit more than 1 year, to be more exact, 15 months. Do you have any figure? Can you guess? What is the number of publications? So 125,000 referred scientific publications on COVID. So, of course, I can't read such a great amount of articles, and I don't think that there is any person in this world that can analyze comprehensively this problem. As of today, perhaps we would require the help of the artificial intelligence, as well as we would require the cooperation from different parties here. But I'm sure that these 125,000 articles contain the recipe how to fight and how to win over COVID-19. Thank you. Okay, Valery Borisovich, thank you very much. You presented us a very interesting and valuable report on the flaviviruses. Dear audience, if you have any questions, this is the time to ask them. Okay, thank you very much for your attention. Okay, thank you. Then our next speaker will B. Sao Min Han, and the report will be about the sentinel surveillance system of chikungunya, dengue, and Zika in southern Vietnam in 2020. The floor is yours, please. We can't hear you, unfortunately. Please, could you switch on your mic? We can't hear you. Please, could you switch on your mic because we can't hear you? There is no sound coming. There is no sound coming from you. We can't hear you, unfortunately. Could you please switch on your mic? We can't hear you. Please, could you switch on your mic? Please, could you switch on your mic? We can't hear you. Then the next presenter, very sorry for this technical issues and difficulties. Who's our next presenter then? Then we'll give the floor to our next speaker, Olga Viktorovna Maletskaya. Olga Viktorovna, are you with us? Can you hear us? Then the floor probably has to be yours. Could you please switch on your mic? Olga Viktorovna, can you hear us? Olga Viktorovna, can you hear us? If you can hear us, please go ahead. The floor is yours. Probably Olga Viktorovna cannot hear us for some reason. Can we connect to Olga Viktorovna somehow and ask her if she can hear us and if she can start her presentation? Okay, probably we'll then go to the next speaker because we can't spend too much time in here. We hope that all the technical issues will be addressed in the nearest future. For some reason, we have some technical issues. The organizers are working on addressing them. Now, then, let's give the floor to Holmerzo Dovlatov, the director of the Republican Center of Tropical Diseases, Republic of Tajikistan, and he'll talk about the progress towards elimination of malaria and measure to prevent its return in the Republic of Tajikistan. Okay, thank you very much. Could you please switch on my presentation? I'd be very grateful. Distinguished colleagues, ladies and gentlemen, I'd like to give you an overview of the progress in elimination and prevention of malaria in Republic of Tajikistan. So it was back in 1960s that the malaria was identified in Tajikistan, and since then, up to 1990s, sometimes we did register some singular cases in those territories that are bordering with the Republic of Afghanistan. And those cases mostly came from the vectors, the transmission carriers that were coming to us from Afghanistan. The epidemiological situation worsened, however, in the beginning of the 2000s. And it was also provoked by the political instability as well as the migration of citizens from southern regions, southern parts. From, as I said, southern parts of the Republic. And in the 1992 and up and through 1997, we saw the rise in the number of the registered malaria cases. And it is connected to the fact, as I said, that our citizens came from the Republic of Afghanistan, and while they were returning to Tajikistan, they brought some new cases. And back in 1997, we saw the peak of this disease, and we registered about 30,000 cases of malaria. Apart from that, it was the first time that the Republic of Tajikistan registered the case of tropic malaria. And by 2001, it accounted for already 5% of the total malaria cases. As a result of some large-scale measures on the territory of our republic, the epidemiological situation started to improve. And the cases of tropic malaria did not appear anymore in 2009. And in 2015, we didn't register a single case of malaria. And this progress was made due to the programs that we adopted back in 1997 and that extended to 2010 and 2015. So in general, we adopted 3 programs on the fight against the spread of malaria. And we adopted 2 strategic plans in the Republic of Tajikistan. The first one dates back to 2015 and 2017, and as of today, the Republic implements the next strategic plan on prevention of malaria in Tajikistan, and it will be active up to 2023. Definitely, these programs and the strategic plan are the result of the work of our government as well as the international organizations that worked in collaboration with us during all these times. Starting from 2015, we stopped the local transmission of malaria in the Republic of Tajikistan. And over these 6 years, we mostly registered 17 cases of malaria. Mostly those are imported cases, while our republic saw the visits from the citizens of other countries. And also our own citizens came from other countries, or they were foreigners. 14 cases were our own citizens and 3 cases were foreigners. You can see it right here in the slide. Mostly our citizens, compatriots, came from Afghanistan, from Gabon, from Pakistan, and they got infected there. And as for the foreign citizens, they were citizens from Pakistan and from Italy and other countries.
This is the stratification of regions in Tajikistan for potential malaria cases. And as you can see on this slide, the red zones are the regions that are on the borderline with Afghanistan, where the potential of new cases of malaria is high. Although, starting from 2015, we don't have any registered cases of malaria, and still our healthcare system is providing for epidemiological and epidemiological vigilance. Speaking about epidemiological control, this is applicable to the regions as it is stated on the border with Islamic State, Afghanistan, where the potential of malaria is high. And to trace out these cases, we are using the passive, proactive, and reactive methods. And notification is made according to the scheme of epidemiological vigilance. The whole information is stored in paper form and in digital form in our archives. We are providing for notification about all cases, imported or local, at the day of evidence in state agencies, and starting from the clinics or first line, the information goes to the Center of State Epidemiological Surveillance, then to the Republican Center for Overcoming Tropical Diseases. Every case of malaria, be it local malaria or imported malaria, should be investigated and subject to the research. Also, as in phases of elimination, we are filling in the documents like notification, ambulance map, ambulance card, history of the disease, epidemiological research, and report. And according to the results of epidemiological diagnostics, we are prescribing the classification of case of the outbreak and provide for anti-malaria events. The information is also mapped by the entomologists. We have facilitated the work for with supposed malaria cases in clinics. According to the Tajikistan Republic decree on malaria, in case of the fever, the blood is assessed within the clinic for malaria, and 3 times during 24 hours, next 24 hours after first admission, for all chains, be it in a village, in the city, or in other state medical agencies, 3 times a day after admission of the patient with a temperature 37 plus degrees Celsius, we are making the tests, triple tests, not to let malaria in. And as I already stated, the same information is also accumulated by the private medical institutions. Speaking about military, we are especially working with the customs along the Afghanistan border. There are many medical agencies and military and military service, and we are providing for scarificators, glasses and drugs, insecticides, and impregnated tissues to protect from the mosquitoes. We are also facilitating work to make laboratory tests in regards to foreigners. In 2018, we've made a research of 257 students. In 2019, 5,493. And in 2020, because of the coronavirus and the pandemics, we had a limited intake of foreign students, but still 1,423 students from India, Pakistan, Afghanistan, and other countries were under research. We also are working out the ways of communication with tourism agencies with the following recommendations, and we are purchasing the hardware and reagents to make a diagnostics of malaria, and in all clinics we have laboratory appliances, microscopes, for example, for in-time research. We've made trainings for 55 specialists who are trained for diagnostics of malaria in the trainings, and reference laboratories for control and provision of high diagnostics quality are working along the country. All positive and 10% of negative responses are delivered to the reference laboratory, to the Republican Center for Secondary Research. We are also making blind crossed tests. And out of the quantity of the research, as I told, more than 70% of preparates are distributed on the borderline between Afghanistan with the highest malaria potential. We also developed national protocol for cases of malaria. We have drugs, anti-malaria drugs, according to the protocol, chloroquine, primaquine, and coartem. And also the national protocol in the new draft of 2014. Also, as we already stated, starting from 2015, we have no registered cases of local malaria, but entomological vigilance is still on set in the regions characterized by high potential of new cases of malaria. What do we make there? On an annual basis, we run entomological monitoring for malaria. We are extinguishing and deleting the points of distribution of mosquitoes. We are steadily running monitoring of resistance to insecticides. At the same time, together with the Ministry of Melioration and Water Resources, we are supporting the following events. On an annual basis, approximately 1,500,000 square meters of channels and collectors are cleansed, and this is the majority. These are the majority of places, so watery places where the mosquitoes are present. So we are also working on the awareness of local population. What do we make? How do we work? We use the 5% alpha-cypermethrin, 5% on the pilot tracks between Tajikistan and Afghanistan. We have epidemiological and entomological vigilance for malaria on the Tajik-Afghanistan border. We are also studying invasive and transmissive diseases in Tajikistan. And although in 2020 the whole system was fighting against COVID-19, we've managed to run one entomology and parasitology research where we made a research of mosquitoes in regions with high potential of malaria cases. And we were also running parasitology research, which means that more than 1,000 of citizens of our republic in the borderline between Tajikistan and Afghanistan were subject to tests, blood tests, to study the plasmoidic features of the blood to exclude chronic diseases. We are making monitoring and revision of the type Glycidae and Psychodidae within the resistance Anodium superpictus to insecticides. All the tests were made in 2019. And this here, in particular, is distribution along the years. We are closely working with the military agencies, and we are also distributing closures for the borderlines with Afghanistan, because I need to state here that in certain places there are 1.5 or 2 kilometers from our republic to Afghanistan. Therefore, we need to exclude the contamination of these regions. And we are in these particular regions. We are conducting the works that you see on the screen right now to clean the contaminated or possibly contaminated regions. And last year we've managed to decontaminate about 5 million cubic meters along the border with Afghanistan. So within our programs and at the realization of our strategy plan, we have the trans-border cooperation. We've exchanged the best practices between Tajikistan and Kyrgyz Republic in terms of certification, because as we know, our neighbor states, Republic Kyrgyzstan and Uzbekistan, they have already got the certificate of WHO on the status of malaria-free country. And to make this, we've invited the Kyrgyz specialists, our neighbors, to exchange the experience here. And we also facilitated a visit of our specialists in November 2017, when we were introduced into the preparation of documents. We've made the cooperative research in matters of leishmaniosm, according to the framework of the trans-border cooperation. And we also facilitated coordination meeting on the issues of malaria and leishmanios in Tajikistan, between Tajikistan and Afghanistan. And we've arrived at a joint statement on cross-border cooperation on malaria in Tajikistan and Afghanistan in 2010 and in 2012. What are the problems and hindrances on the way to elimination or prevention of the risk of transmission of malaria? I want to state from the very beginning that our country is now on the direct way to the certificate issued by World Health Organization, and stating that we are a malaria-free country. We are going along this direction, we are working on it, and by the special decree of the Ministry of Healthcare, we've shaped the Republican staff, where we see not only the specialists from healthcare, but also specialists from other agencies and state bodies, be it Ministry of Defense or other agencies that are related to this issue. And moreover, we are working with the European Regional Bureau of WHO that provided us with new samples of documents for preparation or to the granting of the certificate. And what are the problems? This is the risk of renewal of the local transmission of malaria. This is a high risk, especially in the regions that are on the border with Afghanistan. And because of the high probability, we can see here the parts of Tajikistan that are lying on the border with Afghanistan Republic, and we have a real huge line here. And these territories in Afghanistan, I will show it to you right now, in the northern provinces of Afghanistan. This is the information for 2017 that are on the border with our country, with Tajikistan. For 2017, we see this picture according to province, and these are the regions: Badakhshan, Kunduz, Tahor, Balkh. And these are the provinces of Afghanistan that are lying on the border with Tajikistan. And you may see that in 2017 they had also tropic malaria cases for 3 days. That means more than 3,000 cases in total in these regions are registered. I mean cases of malaria. And primary and secondary malaria sources in Tajikistan and northern Afghanistan have practically the same types of geographic landscape. And the main types of malaria and the fauna are pretty much the same. So the main sources here in Tajikistan and Afghanistan are Anaphylaxis superpictus and Anaphylaxis pulcherimus, and the secondary is Hyrcanus and claviger. And all anti-mosquito actions at the border regions between Tajikistan and Afghanistan should be pointed out on these 4 types, because the other Anopheles types that are distributed on the territory are not transmitting malaria. So we need to preserve the success that we've gained. We need to eliminate malaria further. We need a goal-linked strategy from the side of international organization to cover all the priority issues related to malaria. In the recent years, we see an increase in tourism, in international migration, migration of students from malaria endemic countries, household migrations, and therefore these contingents should be controlled also here, and we need also work on the preventive means. We have not enough resources to provide special trainings, to increase awareness and to accumulate more human power here. We have not enough transport means, modern technical means for insecticides, storage and delivery. And practically in the last years, we don't have the trans-border cooperation with Afghanistan right now. And what are the offers from our side? To coordinate actions to restore malaria-free cases, we need to work with the states that are at the border of Tajikistan, and we need to work on the border in a deeper way. We need to cut down the cases of imported infections by mass screening on the border. We need to provide for cooperative research and work on the territories of Tajikistan and Afghanistan. And we also need to work further on coordination meetings with Afghanistan, with Uzbekistan and Kyrgyzstan to fight malaria in region and prevent cases of imported malaria. And we need to exchange our best practices with colleagues from Uzbekistan in issues of certification. Thank you. I want to thank you for your kind attention. Thank you so much, Haldemurza Davlatovich. Shall we have any questions? So we don't have any questions right now. So please be seated. Thank you again, and I wish you good health. And thank you very much. Thank you to the Presidium, to the Secretariat for inviting me for this great conference. Thank you so much. And the next presenter will be delivered by Cao Minh Thanh, Head of Microbiology and Immunology Department at Pasteur Institute in Ho Chi Minh City, Vietnam. Sentinel Surveillance System for Chikungunya, Dengue, Zika in southern Vietnam. The floor is yours.
Good afternoon, gentlemen. I'm Cao Minh Thanh. I work on Pasteur Institute in Ho Chi Minh City, Vietnam. Pasteur Institute is a regional institute in charge of 20,000 provinces. Pasteur Institute in Ho Chi Minh City direct and implement public health activity and research. I would like to introduce the Sentinel surveillance system for Chikungunya, Dengue, Zika virus in southern Vietnam during 2020. In order to improve the system, I would like to have more cooperation and assistance from the Federal Service for Surveillance on Consumer Right Protection and Human Being Operation Federal. My presentation consists of 3 sections. First of all, I introduce the Chikungunya, Dengue, and Zika virus surveillance system in southern Vietnam. Number 2, I will talk something about the result And number 3, the future orientation. Vietnam is located in the Southeast Asia with a tropical moonlight climate. There are high rate of rainfall and high humidity. The weather is suitable for mosquito grow-up. Southern Vietnam is an endemic area for dengue, hemorrhagic fever, and other arbovirus like chikungunya or Zika virus. In Vietnam, from the 1998, the National Program for Control and Prevention of Dengue Hemorrhagic Fever was built up with 2 kinds of laboratory methods: virus surveillance and serological testing. However, on March 2016, after the first case of Zika were detected in Vietnam, the number of Zika cases were increased. To deal with this problem, Ministry of Health of Vietnam has succeeded to set up the chikungunya, Zika and dengue surveillance system. After that, I will call the CDZ surveillance system. This is the reason why we set up this surveillance in the southern of Vietnam. First of all, I will introduce the activity of this surveillance. For this monitor, we collected on my patient. The disease is characterized by fever and hemorrhagic sign or skin rash, fever joint pain, arthritis. With the bright frame, it looked like to indicate the dengue patient, and with that frame, it indicates the Zika and chikungunya virus patient. In the first 10 months of the last year, 4 sites in southern Vietnam were chosen to establish this system, including Tropical Hospital, Hồng Vương Hospital, Long Thanh District Hospital, and Thới Lai District Hospital. Additionally, with the risk of imported chikungunya case from Cambodia in last October, a provincial sentinel system were taken sample more, including An Giang, Đồng Tháp, Long An, Tiền Giang, Tây Ninh, Đồng Nai, Bến Tre, and Ho Chi Minh City. Having 2 activities for this surveillance, we collect 10 serum samples. They were certified case definition about the week for each site. Collecting mosquito and larva sample to in around confirm positive case. But for this presentation, I just talk about the laboratory result. The diagram illustrates the various stages of laboratory diagnostic algorithm. Several specimens were received from the old Sentinel site were transferred to Ho Chi Minh City. Total RNA will be attracted by Cayam viral adjustment kits and testing by a trial black protein RT-PCR to detect the RNA positive for dengue virus or chikungunya virus or Zika virus. Additional more research including for inoculation of seropositive to the C636 cell line, and for this virus isolate obtained above, we will perform the next generation sequencing by Illumina MySeq to try to identify the phenotype of this virus strain. And this is some result of the CDZ surveillance in the southern Vietnam 2020. Last year, for the CDZ, the surveillance, we got totally 710 sera patients, and we see that dengue virus is the most virus positive case. Positive. It equals 12.8%. After that, chikungunya virus were positive with 0.8%. For Zika virus, we just only got one positive RNA case. The bar chart shows how to group site participants in the positive pathogen result. Can you see that both Sentinel site and provincial site were detected dengue virus? But for Zika virus and chikungunya virus, we just only find out in the provincial Sentinel site, the new sites. That means it is about that chikungunya and Zika virus were co-circulate with dengue virus in the southern of Vietnam. Furthermore, our actual research has chosen some positive RNAs to do virus isolation on the C636 cell line. Can you see on the bar chart, we just harvest dengue virus serotype 1, dengue virus serotype 2, and dengue virus serotype 4, and 4 virus chikungunya virus strain. For Zika virus, we did not succeed to grow up on the C636 cell line. In order to preliminary analysis about molecular epidemiology of G pathogen, we apply next generation sequencing to identify genotype with idea optimize the NGS procedure for the pattern from virus isolate or sera, and preliminary identified virus genotype circulating in southern Vietnam. We improved 3 dengue serotype 1, 2, and 4 for chikungunya virus strain and only 1 serum sample to do whole genome sequencing. Analyzing obtained viral sequence revealed that dengue virus 1 it belongs genotype 1. Dengue virus serotype 2 it belongs genotype cosmopolitan. And dengue 4 it belongs to genotype 1. On genotype is very similar the genotype circulated in the Asian country. We sequencing of Zika virus, it is so that all Zika were found in Vietnam with Asian genotype. They cluster closely with Chinese sequencer. Phylogenetic tree of chikungunya so that on 4 isolated chikungunya present in Vietnam East Central and Southern Africa belong to Indian Ocean class. On chikungunya virus strain posed to essential mutation of amino acids in envelope E1, region E1 and envelope E2. The mutation of acid amine residue 211 from lysis to glutamic acid, and the mutation of residue of 264 from valine to alanine. The mutation are previously reported to be associated with virus adaptive Aedes aegypti. In summary, our research revealed that chikungunya and Zika virus have been exhibited in southern Vietnam and co-circulated with dengue virus. Preliminary genotype of some virus strain recognize that chikungunya it belongs to genotype EECA, Zika genotype Asian. Dengue virus serotype 1 is genotype 1. Dengue virus 2 genotype cosmopolitan, and dengue virus 4 is genotype 1. Because of some restriction, we are having small virus strain of chikungunya, dengue, and Zika virus. So we would like to improve the strategy to collection CDZ sample by opening the K definition to detect suspected patient, and step by step monitoring the diversity of virus phenotype type by type in Vietnam in order to have better disease management and preventive measure of virus. We would like to say thank you for the CDC USA and Nagasaki University from Japan to supply us the reagent for trial real-time PCR and NGS technique. And for virus laboratory team of us, the entities in Ho Chi Minh City, work together with me on this research. Thank you for your invite me to talk in this conference. Thank you for your listening.
Спасибо большое.
Thank you very much for your presentation. Okay, thank you. And now we give the floor to Olga Viktorovna Maletskaya, the Deputy Director on Science and Epidemiological Control at Stavropol Plague Control Research Institute of Rospotrebnadzor, Russia. She'll be talking about Crimean hemorrhagic fever, about the new solutions and how to address this problem. Please, the floor is yours.
Ольга Викторовна, начинайте, пожалуйста. Ольга Викторовна.
Thank you very much. The floor is yours. Distinguished Presidium, distinguished participants at the conference. I will now start my presentation. I beg your pardon for this. Just a couple of seconds. And I will start my presentation. Distinguished participants at the conference, today I will speak about Crimean hemorrhagic fever, and Crimean hemorrhagic fever is distributed through the whole world. We can see the strains in Africa, in southeastern Europe, in Asia, and on the territories lower than 50 degrees of in the northern hemisphere. The cases of this disease are registered on the annual basis in different states of the world, and the quantity is from isolated cases to hundreds. In Russian Federation, the nature outbreak, the nature source of Crimean hemorrhagic fever is about 815,000 square kilometers. It is in the south of the European part of Russia. The disease is registered on an annual level, and up to 90% of all cases are registered on the territory of the so-called center of this source in the region of Stavropol, Rostov region, and Kalmykia Republic. And the epidemic manifestations are registered in 6 federal subjects in the south of Russia. Moreover, we have imported infection in Moscow to Voronezh from the territory of Crimea. The constant episodology and epidemiology monitoring of the source of the disease is speaking about the widening of the area of the virus of Crimean hemorrhagic fever from the main reservoir, and ticks are represented broader and broader, and this is resulting to a severe epidemiological situation in the country. And as of now, it is very topical for us to understand new forecast methods and measures to be prepared and to get an adequate forecast of the situation to be able to in time organize anti-epidemic events. The forecasts of the epidemic for the next year are, as a rule, built on the basis of calculations calculation of the ticks amount. We are collecting the information on pre-imaginal phases in this period, and the quantity of ticks and the way out from the winter passivity to the active stage is depending on different factors. This is, of course, the natural factors, climate that is affecting all the phases of reproductive development of the tick in winter and in other times of the year. The quantity of Hyalum marginatum is depending on the diseases, of course, the quantity of the diseases. But the character of epidemics and the level of morbidity is developed by different factors. We've compared the spring abnormalities, the southern climate, with the quantity of Crimean hemorrhagic fever cases in this region. And as you see from the slide, the quantity of diseases every year was proportional to the abnormal values of temperature, and it is equal to the abnormalities. We've compared the abnormalities and increased air temperatures resulted in an earlier activization of the ticks, of the imagos, and extension of the period of their life, and acceleration of their quantity. And to make a better forecast for epidemic situation for this particular disease, we've studied the possible factors of biotic nature, abiotic nature, and social factors. Mathematical methods were also used. We've used the indexes, and then we've made the calculation for the mathematically significant values. Then we created the quantitative forecast for every administrative region of one subject of Russian Federation to check this model. The results of a forecast were visualized on the map, which provided for obvious picture of epidemiologically unsafe territories for the next period. This forecast was probed on the retrospective data, and starting from 2017, we are running operative forecasts for the situation of, Crimean hemorrhagic fever. And this forecast is provided for the Rospotrebnadzor governing bodies for the segment, with the recommendation on the necessity of enhancement of prophylactics and preventive events in a certain administrative region. The results of a research have proven the effect of migration of birds, because a very important part of epidemiology of Crimean hemorrhagic fever is monitoring of the initial points of Crimean hemorrhagic fever, which is related to migration processes. Here on the slide we see that seasonal and intraseasonal migrations of birds are affecting the distribution of genetic variants of the virus. We've used the phylogenetical methods, bioinformational analysis, which provided for a definition of genetical type of the virus circulating on a certain territory, and to run the analysis of molecular evolution of these variants, which can be useful at epidemiological research and which can be used at the deciphering of the outbreaks. And the research of modern and contemporary and use of contemporary methods of phylogenetic analysis, for example, Bayes phylogenics methods, provided for construction of space and time distribution of the virus. And we also could study the speed of evolution of the virus, so in relative terms, understand the intervals of shaping of genetic strains, understand the initial regions of these viruses and ways of migration of these variants. And we also could define the efficient changes in population of Crimean hemorrhagic fever during a certain period of time. And we also used these methods to set the following. On the territory of the Russian Federation, we have circulation of the Crimean hemorrhagic fever in 6 subtypes within 3 main genotypes that are represented on this slide. The major genotype is Europe 1. Within Europe 1, we have Rio sorts, Rio combinants of virus. Genotype has predominantly territorial binding. So, for example, here in mixed areas of this particular genotypes of Crimean hemorrhagic fever, we see Rio sorts variants of the virus. We could also see the virus genotype Africa 3 genotype in 2013 on the Stavropol region. It also shows that there is a possibility to get the types, new types of Crimean hemorrhagic fever from other regions of the world, and therefore we need to trace its activity. Further on, we've made the analysis of molecular and discrete geography. The analysis included nucleotic chains of 100 strains of the virus related to all known genotypes for which we know the year and the region. On the basis of a full-scale S-segments analysis, we've made a phylogenetic tree of genome of the virus with the maximum sufficiency of clades, and with 95% we could understand the speed of the evolution of the virus, 89.9 x5 per site in a year. The age of the virus of Crimean hemorrhagic fever was 1,684 years. Genotype 3, 125 years of age. Oh, Europe 3, I beg your pardon. And the strain of genetic lines Europe 3, Africa 1 are having one and the same root that was circulating on the territory of Africa. Predominantly. The genetic line Europe 3 is developed as one arch about 1,415 years ago, and the strains of genotype Europe 3 was entered Europe from the territory of Africa, and then further on it circulated in the southwestern part of Europe, predominantly in the southern part of Europe, and on the territory of Russian Federation. Earlier, the Mesofender research built up the model of the Crimean Congo hemorrhagic fever from Congo to Europe that showed that the introduction of virus of Crimean hemorrhagic fever had 2 steps in its history. The first step was genetic line Europe 2 stem, that the strain that was coming to Europe with the strain Europe 3, and then through Turkey it went to the Balkans with the strains of Europe 1. And to provide for a more clarified model of for genotype Europe 3, we need to conduct a more in-depth study of the strains that are circulating right now in different regions of the world, and particularly in Europe. And correspondingly, we need to perform full genome sequencing here. To understand the time and to define the time of shaping of genetic subgroups within the genotype Europe 1, we also performed analysis of molecular hours and screening of the geography. The analysis included nucleotic chains of segments from 56 strains of genotype Europe 1, about which we knew the time and the region of these strains. We could calculate the speed of evolution, which is 4.7 to 10 x5 nucleotic replaces per site per year. We now know the age of genotype Europe 1, 562 years, and we see that the distribution of the virus of Crimean hemorrhagic fever, genotype Europe 1, it was started from the Western Asia, Iran and Turkey. And we see a tendency of one and the same source in the for the genotype Europe 1 that was going to the Balkans, to the Crimea, and to the Southern Caucasus in Russian Federation. And we need to understand here that through Turkey up to the Black Sea, from Iran to the Caspian Sea and to the Astrakhan region, along Volga River, we see the main ways of seasonal migrations of birds from the southern Eastern Europe to Africa. And this is also a possibility for the Crimean hemorrhagic fever to go from Africa to these regions, back and forth. The reconstruction of demographic history of population of the genotype Europe 1 Crimean hemorrhagic fever in Russia showed us that the activization of the nature herd source in 1999 and further growth in the morbidity are coinciding with the results of enhancement of population of the virus. The peak of the diseases cases is registered in 2007 to 2008, and we here see then from 2005 until now the efficient size of population of the virus remains unchanged, which is speaking about the stability of population of virus of Crimean hemorrhagic fever as of now. And at the same time, according to the preserved we can state that there is the possibility of Crimean hemorrhagic fever to be registered further in Russia. So, at the end of the day, we may state that we now have the better, we have a significant betterment in the geoinformative systems and forecasts. We've studied the strains of virus in different genetic lines, and we've managed to describe new genetic subgroups. Crimea, we have the description of reassortant variants of virus. We now know the speed of evolution, the age of genotype, and the sources of the strain that is circulating on the territory of Russia. Thank you so much. Thank you very much, Olga Viktorovna. Distinguished colleagues, as of now, we are concluding our conference. Unfortunately, we are out of time. There is only one presenter left. Thank you very much. We want to thank all of you for your kind attention.
Уважаемые коллеги, закрытие конференции будет в этом же зале, да, в этом же зале в 16:00. Да, давайте уберем.
Distinguished colleagues, it coincided in such a way that the second day and the concluding day of our conference takes place here, and not very far from that, in this very center of Moscow. The address by the President of the Russian Federation to the chambers of the State Duma of the Russian Federation and to the Federal Assembly has just been concluded, and to my great satisfaction, I've heard a very strong message. It was a very extensive one and emotional one, and it was very well structured when it comes to the state strategy. And a lot has been also said about the sanitary shield of this country, about the necessity to enforce everything and to do our utmost to raise the shield. This was the task set to us by the President of the Russian Federation. We've already has started to do that, and we had started to do it even before this words. So what I mean is the topic that we've been discussing over these 2 days is especially relevant for the Russian Federation. That has been confirmed today by the President's words, and it is especially relevant also for other countries. And I'd like to remind you of the President's words that we heard yesterday, that no country in the world could fight against this pandemic alone. Only by joining our efforts we could achieve the results that we expect. And the situation today and the results of our discussion once again confirm the pressing nature of this topic. The especially wide and large participation in this conference over these 2 days. These 2 days that were filled with interesting discussions and presentations. We took part in 21 sessions, and 120 reports have been presented. So each session consisted of 10 reports. This is a large and extensive work. As to the filling and the presence of our rooms, each room was filled up to 40%. We have about 200 participants in this conference offline, so I can tell you that almost everybody participated on 100%. And we considered the biological security and safety, epidemiological well-being, response to the emergency situations. Also, we analyzed the data. We talked about the scientific and technical cooperation. We discussed the challenges as well as the cooperation of the civil society. Definitely COVID-19 and other infectious diseases, as well as we always do that when we gather at this conference once per 2 years, we focused on vector infections, hepatitis, HIV/AIDS, and today the President separately mentioned hepatitis C, and this is one of the vectors of our activities and the topic that we discuss. I would like to thank UNAIDS for their great input in the organization of this conference. I'd like once again to remind you that we've been working for 10 years in Eastern Europe and Central Asia on the issues of rendering technical assistance and fight against HIV and AIDS, and numerously, we underlined and mentioned that this project of technical support is especially relevant and important for those countries who receive this help and aid. And the Consultation Council of the Russian Program of Aid once again estimated and underlined the importance of these activities. I would like to mention that the coordinated help, jointly with analysis of the effect and economic efficiency, mutual accountability, lays the foundation for rendering assistance to the countries in the Eastern Europe and Central Asia. And this time, once again, we organized a number of regional consultations. We compared our notes when it comes to the reforming of the WHO system, when it comes to the response to the emergency situations, and also we talked about the new political declaration drafting from the UN on the topics of HIV and AIDS. And this topic includes a lot of different aspects, of course. I don't think it was that easy to discuss all these aspects extensively, but like that to mention that almost all the elements and topics were discussed. To some of them we paid more attention, to some of them less, but still there are no topics that haven't been voiced or discussed during our deliberations here. And sincerely, I'd like to thank all the participants. I expect that you'll join my words and support my words, and I'd like to thank our leaders of this conference for their address in the very beginning of our conference. I mean the address by the President of the Russian Federation, Vladimir Vladimirovich Putin, as well as Tatiana Alexeyevna Golikova, as well as the addressing from the Federal Assembly. It is very important for us to see that such a large attention is paid to this topic that we've been discussing for these 2 days. I'd like to thank all the participants who presented their reports as well as their opinions. I'd like to state that more than 4,800 delegates were presented and participated in our conference. So we had also 4,884 of online participants. Due to our technical capabilities, we could enlarge our audience. We had representatives from 78 countries of the world, 7 international organizations, and business representatives. So the male participation was extensive. 63% of participants were male participants, and 37% were female. We had 24 broadcast channels in 2 languages on 3 platforms and in social media. So over these 2 days, we've got more than 12,000 views, and this is not the final results because we will finalize them a little bit later. And now I would like to give the floor to the distinguished guests of our conference, to our partners in the Eastern Europe and Central Asia, with whom we have 6 projects when it comes to the prevention and fight against the infections. I will not mention all the projects because those are that we discussed over these 2 days. And first, I'd like to give the floor to Jamaldin Abdulovich Abulzadu, the Minister of Healthcare and Social Safety from the Republic of Tajikistan. Please, the floor is yours. Distinguished members of the panel, distinguished participants to the conference. First and foremost, let me extend my sincere gratitude to you, Anna Yurievna. Thank you for inviting us to take part in this international conference on the problems of HIV infections and epidemiological well-being. Once again, I'd like to wish all the participants to be healthy, to be successful. As we know, the infectious diseases is one of the pressing problems. And as professionals in this field, we know that more than 10 or 15 million people are dying every year because of these diseases, because of the bad consequences. And this conference that was devoted to the pressing issues concerning infectious diseases, and in particular HIV and AIDS, as well as COVID-19, all these issues are very pressing, and this conference was to exchange our knowledge, experience, and I do hope that the participants to this conference got some new information on the new methods of the prevention of infectious diseases. And especially I would like to appreciate the role of the Rospotrebnadzor of the Russian Federation, and in terms of the supporting our healthcare system and protecting our population. And it expresses and demonstrates actually my respect, and my participation is also confirms it. And we do hope that the program of technical support from the Russian Federation will be continued in the Republic of Tajikistan. And I do hope that we'll have another opportunity to gather and to discuss our achievements and developments. And to conclude, I'd like to thank all the participants for your active participation, and I would like to wish everybody to stay healthy, successful, and I do hope that you will achieve the results that I expected within this conference, and I do hope that it will add to the system of healthcare and the fight against the contagious diseases. Thank you. Okay, thank you, Jamaldin Abdulovich. And now I'd like to give the floor to Elena Manukovna. Elena Manukovna, the First Deputy Minister of Health from the Republic of Armenia. We've been working together for many years. So, Elena Manukovna, please, the floor is yours. Thank you very much, distinguished Anna Yurievna, distinguished colleagues. I'd like to thank you for this large and very useful work that we conducted over these 2 days. I'm sure that during this time we had the time to exchange our opinions on the resistance to the epidemic, but we also had the time to view the beauty of this city, the Moscow. So mainly during the pandemic, we were communicating in an online format, and here we could also talk in an offline format due to this conference. The sessions discussed different work that has been conducted by different countries. We exchanged our experience, the information, we shared our successes and lessons learned. The agenda has become a wider one, and new challenges have been added to it. Only jointly, by moving together and by marching forward with our friends, we can resist all the challenges that we face. And I'd like to use this opportunity and thank the Russian Federation for the help that we've got over the last year in our fight against the pandemic. The 2 days of a live and online communication gives us confidence. We establish direct contracts. We see the cases of real cooperation between our countries. Our specialists talk to each other, and all this serves as a bedrock for the creation of epidemiological well-being and the creation of healthy society. Sincerely, I would like to wish everybody to be successful, healthy, and see you very soon, I hope. Thank you. Thank you very much for Elena Manukovna. And now I'd like to give the floor to Alexander Alexandrovich Tarasenko, the Deputy Minister of Health of the Republic of Belarus and the Chief Sanitary Physician of the Republic of Belarus. Thank you, Anna Yurievna. On behalf of the delegation from the Ministry of Health of Belarus, I'd like to thank you for the conference on epidemiological well-being that you, Anna Yurievna, jointly with your professionals organized. And also some other countries supported this initiative. Indeed, it was meant to exchange the innovations in the field of science as well as our practical achievements. I definitely seen it when I conducted the 17th session on the vaccine manageable diseases, and it was very interesting to listen to the scientific institutes. They talked about the prospects that are ahead of us, and of course they were proceeding from the retrospective analysis. So jointly we discussed not only the prevention of HIV infection, but we also touched upon a lot the coronavirus infection, the novel one, and we mentioned many other diseases. I believe that the main points that were discussed over these 2 days on this platform are those points connected to the biological safety of the EU countries, the CIS countries, and the countries of the whole world. Anna Yurievna, thank you very much for the support that you rendered and continue to render to the Republic of Belarus. I can definitely tell you that we do feel your support in terms of the science. It is a very solid one. Thank you for the technical support that we receive. We've been in cooperation when it comes to the immunity studies, the sequencing of coronavirus strains, and of course, the project that we have within the cooperation between our governments, which is the creation of the development of vaccines, maybe not particularly the development, but the implementation of the filling in of the vaccine on the territory of our republic. I believe that this project will ensure our biological safety against the new coronavirus infection. And in particular, this will be reaching the citizens of the Republic of Belarus. And of course, we will not forget about our neighbors. Once again, thank you very much for your participation. I'm very grateful. Have a good way back, and let's be successful with our great deliberations for the preservation of life and health of the citizens in our countries. Thank you, Alexander Alexandrovich. And now I would like to give the floor to Lumbek Vuktusulovich, the Minister of Health, the Deputy Minister of Health and Social Development of the Republic of Kyrgyzstan and the Chief Sanitary Physician of the Republic of Kyrgyzstan. Unfortunately, Lukbek Buktusanovich Bukturganov didn't have the time to get back from the embassy. You know that today some very important events are taking place in the Republic of Kyrgyzstan, and I would like to send him my best regards and gratitude for their active participation. And by this, the program of our finalizing plenary session has been exhausted. But to sum up and to finalize, I would like to once again say that the geography of our event is a very large one. It is quite unexpectedly large. And when we were planning this event with an online participation of more than 200 people, of course, we did understand the responsibility that we had to bear, and we tried to organize it all in such a way that we wouldn't put anybody at risk when it comes to the current epidemiological situation. We didn't want to present any risk to anybody, anybody who participates in this conference. I do hope that you could feel this care from our side and the requirements that we established on the measures to be respected. We believe it's very important to show that even against this difficult backdrop, we can conduct such events, but we should follow some very strict and clear rules. I would like to thank you for your participation. I'd like to separately also underline that the discussion of the topics that we were gathering over we were discussing over these 2 days, it involved the representatives of the public sector, international organizations, scientific bodies, and the private sector. And it all allows us to state that we are striving towards the progress in fighting against the current challenges. The pandemic does not have any borders and limits, and there are no limits and borders on the in the environment. And we have to be very strict when it comes to the formulation of rules on our common epidemiological in our current epidemiological environment. We have to do this, we will do it. I believe that this is the key to success in winning over the coronavirus, and definitely the new infections that will come. This is evident that something can happen, and well, when it has happened, once again we have understood that we have to consolidate our efforts, and we have to maybe apply more efforts to protect the health of those people whose health we are obliged to protect. All the aspects and elements and topics that we voiced on the platform of this conference, in the reports, they all are included in the finalizing document of this conference, the epidemiological well-being. If you allow me, I would like to read out this text, and if there are no contradictions, then we can publish it as and adopt it as a finalizing communique.
The International Conference on Epidemiological Well-being, organized by the Federal Service for Surveillance on Consumer Rights Protection and Human Well-being, together with United Program UNAIDS, under the support of the government of Russian Federation, with participation of WHO, was held in Moscow on 21st April 2021. The conference was attended by more than 4,000 specialists out of 70 countries of the world, including the heads of the state organs, medical specialists, agencies, state agencies, representatives of the scientific society, business society, heads and experts from the key international organizations. The conferences were attended by the speakers from Eastern Europe, Western America, Southeastern Asia. The conference united scientists and political leaders and opinion leaders from the regions to work in the synergy with various specters of healthcare. Within the events, the results of new scientific works were delivered and showed in the scope of the fighting against infectious diseases. In different countries, we've managed to represent the results of coping with pandemics. The coronavirus, SARS-CoV-2, were a huge challenge for many countries, including the Eastern Europe and Central Asia. The efforts that were put into life during the last 10 years were hindered. The COVID pandemics resulted in many social problems that are negatively affecting the life of people in the regions. And we understand that in one solely country we are not able to cope with this situation. This situation should be coped on the level of united efforts by the member states, by partner countries, and by the whole scientific society in terms of operative reaction to the threat. But still, pandemics became a trigger for enhanced development in technologies in epidemiological field, in bioinformational technology, in forecasting, treatment, and prevention of diseases, infectious diseases. The fight against infectious diseases is based on the introduction of the international medical and sanitary rules. We need to introduce these international rules, but not change them further as of now, because we need to understand the role of the rules for within the epidemics, the framework, and within the economy. We are also discussing the issues of the reform on the level of WHO related to the sanitary and epidemiological state. Also, we are taking into account the preparation of UNAIDS in terms of fighting against HIV, fighting infections with high contagious and epidemic potential, and we are offering the political declaration with due regard of international contexts. In our cooperation for the better epidemiological well-being, we need to take into account the following divisions: the development and realization of plans for cooperation in sanitary and epidemiological threats on the international level, creating of international level in operative cooperation on the level of agencies, healthcare agencies within the member states, united system of regional vigilance and efficient reaction to epidemic potential diseases on the united Eurasian space. The development for protocols to fighting the infections together with UNAIDS, United Nations, and its agencies, thus creating a global network for counteracting the infections. We are enhancing our values and our knowledge base also in terms of betterment of qualification of medical specialists in infectious diseases particularly. We are rendering the material in technical support and trainings in terms of reaction to sanitary and epidemiologically cases in in forecasting, in diagnostics, in treatment of diseases, and in provision of cooperation on the scientific level. The participants are supporting the ideas of epidemiological well-being that will be voiced on the next meetings of the Commission's coordination councils on HIV/AIDS and during the next sessions of WHO and UNAID. Distinguished colleagues, do you have any other comments or suggestions and offers according to this text? If no, then let me announce this statement as promulgated, and we will put it on our website for our further use. At this, the conference is arriving at its end. Distinguished colleagues, I want to thank you again for your kind participation, active participation, and from all of us, I want to thank the facilitators and organizers of the conference, the ones who were staying behind the scenes, the ones who were working on the agenda to make it clear and comfortable for us to establish our work. I want to say thank you to the ones who gave food to us, who was interpreting for us, for the ones who was cleaning the premises, who was every time working on the control on the perimeter of the building and within the building, the ones who were protecting us, who were preparing all the premises to our work, to the work of our sections, sittings and meetings of our conference. Thank you very much. And again, I want to state that I was really happy to see you offline here in Moscow. We tried to cool it down a little bit because now it's raining a little bit, but it is providing for more comfort. Moscow now is in a great mood, in a great state, and even if it will be not only raining but snowing, I think and I hope that you will be delighted by staying here. So please use this possibility to walk through Moscow, to go into our restaurants. And fortunately, we don't have any severe limitations and special limitations that would hinder your presence in Moscow. So I do hope that we will meet again, and thank you again very much for being offline today together with us, and I really appreciate your readiness and eagerness to take part at our event. Thank you so much. I wish you good health, success, and have a great results in our common activities. Thank you.
Спасибо.
Thank you so much.